Right, good morning, everybody. Thank you very much for moving down. You're all very welcome today to the Parents' Day. It's day 2 of the conference. We had a very successful day yesterday with lots of very, very good speakers talking to us about the various aspects of tuberous sclerosis. So we look forward to a good day today, but remember, at the end of the day, it's the Parents' Day, and we want your views and your opinions on what's happening. And we want to try and promote as much discussion as possible. Now, unfortunately, there's a change to the programme because Sergio, who's from Warsaw, mistimed his plane, and he was leaving the timings a bit tight, and he might have missed his trip back to Warsaw. So he's going to be replaced to talk about epilepsy by that well-known epileptologist, Professor Andrew Green, from University College Dublin. So Andrew's going to have a chat, and we're going to go through it all, and we'll talk a bit at the end. In my talk at the very end, though, have quite a large section on living with epilepsy and the problems of living with epilepsy and tuberous sclerosis. Anyway, we'll welcome Andrew, and thank you very much indeed for stepping in at the last minute.
Thanks very much, Charlie. Yes, just as some of you may already notice, Epilepsy Ireland have a standout slide again, which is obviously very helpful for a lot of us. Thank you very much. Yes, they have a booklet here about living not specifically with epilepsy and tuberous sclerosis, but epilepsy in general. So I got volunteered, if that's the right word, to present on behalf of Sergiusz, possibly because I've known him for about 30 years. He and I collaborated since something's happening here, since the late 80s. Sergiusz is a pediatric neurologist from Warsaw, and he has been involved in tuberous sclerosis probably since about 1984, immense time. He also has done a lot of research. He's been involved in genetics. He worked with an American group, David Kwiatkowski, in Boston. Again, like many of the Irish doctors, Polish doctors have very good connections with Polish colleagues across the world and use those for advantage and also for the advantage of the patients. He's also been running research studies in tuberous sclerosis, including a large multi-center. And so his expertise and his interest is in both treating and potentially preventing epilepsy in children with tuberous sclerosis. But this is Bournville on the right. He's one of the French guys that described the tumors and the tuberous sclerosis, and that's some of the original photographs from the time. I'm not going to go too far back into the history of tuberous sclerosis.
You stand here with these mics, or we need to move this one?
Sorry, is that not working? So Sergiusz was going to talk about epilepsy and about EEGs in infants with tuberous sclerosis, looking at how EEG monitoring early in children with tuberous sclerosis can help, and looking at new ways of trying to improve things. This is a slide that you'll see a lot, which is a description of tuberous sclerosis. I mean, it may be repetitive for those of you who have already read some of the leaflets. It is an autosomal dominant genetic condition. There are 2 genes, tuberous sclerosis type 1 and tuberous sclerosis 2. I'll talk about those later. And there is a predisposition both to developmental anomalies of the brain, which are called tumors or hamartomas, and also the development of benign tumors in many other organs, the heart, kidneys, the brain, sometimes the liver. And there are lots of long names that go with the various types of growths, benign growths that occur. In the heart, they're called rhabdomyomas. In the kidneys, they're called angiomyolipomas, which most people call AMLs. And in lung, Sergiusz has wisely not actually put in the first name, which is called, the long name, which is called lymphangioliomyomatosis in the lung, also known as LAM, which occurs mostly in adulthood and much more in women than in men. You can get the skin changes. And then in the brain, obviously, you can have the epilepsy, intellectual disability, tuberous sclerosis associated neurodevelopmental disorder known as TANDem. Agnies is going to talk about that later on. And also tumors which are called subapendical giant cell astrocytomas or SEGAs. So epilepsy is very common in people, adults and children with tuberous sclerosis. And most of those people will develop seizures before the age of 2. And there can be a significant association with epilepsy with intellectual disability, delayed development, and autistic traits and other behavioral issues, as well as speech delay. And it's clear, and this is a table that's showing the age at which a child would develop epilepsy from less than 6 months until greater than 5 years, and then looking at how those children's development will do, whether they have levels of intellectual disability, profound to mild. And it's clear from this data, you can take my word for it, and from Sergiusz, is that actually of the children who have epilepsy before the 1 year, 82% of them will have significant levels of intellectual disability, whereas the children who have seizures later than that have significantly less intellectual disability. And there has been a very long discussion about the role of intellectual disability and epilepsy and how well they are tied together, and the argument of trying to say that if you can get on top of epilepsy, your developmental problems may be better, which is a very important principle to try and get to the bottom of. You can actually diagnose tuberous sclerosis in the UK 2000 study, where they looked at follow-up of people found at birth to have tuberous sclerosis. About 20% of people were actually diagnosed even before they were born, based usually on the finding of a scan of your baby's heart, which showed benign tumors, rhabdomyomas in the heart, because that's common in a lot of the babies with tuberous sclerosis. And now with the advent of MRI scanning on women when they're pregnant, looking at their babies in the womb, it's possible to see some of the brain scan changes on a baby even before they're born on the scan, showing that they have tuberous sclerosis. An important point that Sergiusz would make, and a lot of people would agree with him, is that in getting epilepsy, and this isn't exclusive to tuberous sclerosis, there is a latent period when there are problems with the development of the brain before it actually manifests as developing seizures. Obviously, when seizures develop, you can start treatment. But the question is, can you identify something during the latent period that actually might mean that you could intervene earlier before frank seizures development? And there could be lots of things that can cause triggers to epilepsy, not just tuberous sclerosis, but damage to the brain, cell damage, sometimes birth injury. But if you were able to get in earlier, the argument is you may be able to help with the intellectual disability and autism. And there may be markers you can look at in blood samples or other tissue samples from children at that stage, which might point towards development of epilepsy. And Sergiusz suggested, this is 2007, 16 years ago, that actually maybe in children with tuberous sclerosis, because you can diagnose them so early, often before they may get epilepsy, that there may be an argument about treating with anti-epileptic drugs before seizures. And this is a video I'm not going to show you about a child with tuberous sclerosis. And then they looked, this is a study not from Sergiusz, but from an American group, looking at EEGs. The EEG is the brainwave pattern of all of us, and there are specific brainwave patterns that you can see that point towards particular types of epilepsy. And you can use sometimes these as markers for impending epilepsy. And this is a study done from various centers in the US, showing that actually you may be able to predict, based on doing EEGs on babies before they develop epilepsy, babies with tuberous sclerosis, before they develop epilepsy, and maybe predict those that then might go on to get actual frank seizures. And then Sergiusz had done a small study, which was actually 10 years ago, of Polish children with tuberous sclerosis, babies, looking at them by looking at treating them before the seizures, looking at their EEGs, and treating them with a drug that's specifically of benefit in tuberous sclerosis, vigabatrin, treating them according to their size, and giving them 2 years of treatment, and showing that actually the outcome in those small groups was actually better for the children who were treated with vigabatrin in what was called the preventative group compared to other children who were monitored. And also, although it wasn't very statistically significant, that there seemed to be an improvement in the intellectual abilities of children, although they were only monitored at the age of 2, of how they were going to develop in those who were treated with vigabatrin and those who were not. And he's followed that up, and that's still held true later on, as those children are now 7 or 8. And that actually led to a big study which was funded by the European Union, which is called EpiStop, as in Stop Epilepsy, which Sergiusz led, which involved a whole load of work packages and a whole load of centres across the Netherlands, Poland, Italy, France, looking at children, babies who were diagnosed at birth with tuberous sclerosis, looking at markers, both looking at the EEG, the brainwave in those children, and also then looking at particular molecular biomarkers in blood to see what might be a marker of why children might or might not develop epilepsy. And then in addition, to say that early treatment to test the theory, his original small paper in a larger scale, to say that whether you treat seizures early significantly reduces drug resistance in neurodevelopmental delay. And so this was looking from how long the aim was to try and work out the endpoints we used was from the time that the baby was born to when they did or didn't develop a first seizure. And then also looking at the types of seizures, what types of developmental problems they had as well. And so the babies were diagnosed at an early stage with tuberous sclerosis. And then they had serial studies of their, I'm getting seriously echoey here, sorry. Then went on to have molecular biomarkers looked at and then given treatment or not. Other specimens were taken, so it was blood for DNA and RNA studies, looking at proteins in serum, looking at genes and proteins involved in epilepsy. I'm not going to go through those yet because they're not actually back yet as results. 100 patients were screened to enrollment across all these centres. There was thousands of EEGs were done to look, and the children were followed up 4 or 6 weekly all the way through what's part of the project. So of the 101 patients that were studied, we managed to get 94 who were included. Some of them actually didn't have tuberous sclerosis and therefore excluded originally. And then some were given preventative treatment or randomly advised, assigned to preventive treatment. Others were on an open label study. Some of them actually developed seizures before they actually got into the trial. So that was a complicating factor. And it was clear that in those who were treated, that actually the number of seizure-free patients was higher in those that were treated before any frank seizures developed compared to standard. And then the number of seizure-free patients, again, was also improved in the observational group. And the initial data certainly suggested also that developmental problems were less in those children who were treated early. So that was a really important finding at a much bigger scale. And surgeons would certainly argue that now that children with tuberous sclerosis should have EEGs done from when they're born as babies, if they're known to have tuberous sclerosis, so that if they have any evidence on the EEG, they should be treated specifically with vigabatrin. This study would really support that. And that in doing that, you may improve the amount of intellectual disability that a person may or may not have as a result of their tuberous sclerosis. So that's a really important finding. There may also be suggestion that some of the evidence of autism spectrum disorder may be better in those that are treated. And this is a study that she replied a report at the time. This is looking at autism scores, ADOS and AST scores. And that the EEG may help predict the outcomes. And then again, it's from the same study. And that a younger age of finding first epilepsy on it was associated with lower cognition, but the treatment certainly seems to help to improve it. They also looked in detail at the brain scans, and this was done by the Dutch group. And this was looking at MRI scans in the baby in the womb, not after they're born. And when they were done, that there seems to be an association with the amount of brain involvement on the brain scans on infants in the womb before they're born, which may also predict whether or not there's a neurodevelopmental problem that's going to happen as well. So it's all pointing in the same direction. And again, when you do the same thing on babies after they're born, again, there was an association with characteristics with epilepsy and neurodevelopment. So there were particular MRI changes that pointed at what are called tuber-brain ratios in the brain scans that may point to whether or not a child may have more developmental problems. There are lots and lots of samples here that were tested. None of these have actually been formally reported as yet. I understand from Sergiusz that's coming through later on this year. But he's given some preliminary studies that I'm not going to go through at this stage because I'm not quite sure how to interpret them as much as something else. But they're looking to try and see if there's things in blood samples or other biomarkers that might distinguish children with tuberous sclerosis from those that don't. That might be a predictor of epilepsy, might predict whether they respond to epilepsy treatment or not, and whether or not that's going to be something that has a long-term benefit. So from this, Paolo Curatolo and Sergiusz, Paolo Curatolo is a pediatric neurologist based in Rome, who's also been involved in tuberous sclerosis for many, many years. And they have both come up with a recommendation for children with babies with epilepsy that actually they should have an EEG every month in the first 6 months and every 6 to 8 weeks thereafter, to monitor very closely whether they may or not be developing epilepsy. and that if you find evidence that treatment should be initiated even before the child may actually have frank seizures. And the drug that should be best used is vigabatrin. So that's a really important conclusion for dealing with one of the biggest problems for people with tuberous sclerosis in trying to intervene early and make the outcome better for those children. He's now moved on. There's a new study which is undergoing, and I don't have any results for it, which is actually looking not just at vigabatrin, which is the well-known anticonvulsant, but also rapamycin, which is an mTOR inhibitor, as a way of trying to improve again the outcome for children who have seizures with tuberous sclerosis, not just infants, but also but following up as they get older, and they need to have evidence of cortical tuber. This is a Polish study, and it's going to take several years to get to the bottom of it. But the idea is that this may significantly improve things, and because we know that rapamycin may have an effect, and it's already been something that has been used in some children with drug-resistant epilepsy, even though it may not necessarily make a massive difference, it certainly contributes to the management of drug-resistant epilepsy in tuberous sclerosis. So Sergiusz never did all of this on his own. There's a few people that I know. There's Paolo here, David Kwiatkowski at the back, and many other people that have been involved. Han there, who's the radiologist. And he obviously wanted to thank all the patients that are involved, not just the Polish patients, but the 100+ European families who contributed to the successful EpiStop study. So there's a significant amount of progress in looking at how to manage epilepsy and tuberous sclerosis, knowing that it's one of the most difficult things to treat for many families who have children with epilepsy as part of the tuberous sclerosis, and that the collaborations that have been built through the EpiStop are going to be continuing in developing further studies for tuberous sclerosis. Interestingly, I was looking last night at the Register of Clinical Trials which is all the clinical trials across the world, and currently there are 97 clinical trials and research in tuberous sclerosis across the world, which I think is a really good thing. Some of them are observation studies, some of them are looking at new types of drugs in tuberous sclerosis. So there is a lot happening, even if it doesn't sound like it at the moment. Okay, so I'm really sorry that Sergiusz couldn't be here himself present this. I've given you a very short and potted version rather than something that's going to teach you a whole lot about it. But I hope that's been of help, and I'm happy to try and take any questions. I am not going to be able to answer questions about particular drug types and dosages, which is something that's beyond my ken. Thank you very much.
Thank you, Andrew, very much indeed. That was interesting messages there, I think, about the management of epilepsy in tuberous sclerosis and I suppose the role of epilepsy in, unfortunately, the evolution of intellectual disability. Anybody like any questions that we'll try and answer, or you'd like to raise any points? As I say, we will come back to the subject of epilepsy this afternoon and talk quite a bit about it on sort of the practical aspects of living with epilepsy and how to manage it, especially within the confines of tuberous sclerosis. Anybody, any points to make? If not, I'm going to ask Professor Doherty to make a few points about epilepsy, especially in the adults.
All right, well, that research is quite complex. So if you kept up with that, you're doing very well. But I had some trouble with some of those slides myself, let alone.
Okay.
So I'm happy to answer any questions. I mean, I suppose it's worth for this audience putting epilepsy in TS in the context of epilepsy as a whole. Okay, so we have about nowadays we have about 1% of the population with epilepsy, so maybe 45,000 people in Ireland. And given that we have we think somewhere in the region of 700 individuals with TS, and if 90% of those have epilepsy, that's about 600, I suppose, people of the 45,000. So it's a relatively small amount of the total burden of epilepsy in the country. But the difference, I suppose, is that in general, we expect that epilepsy in people with TS is harder to treat. It's at the more severe end of the scale. It typically affects people at all ages, and the treatments are People are often on multiple medications, as some of the audience might be. Can I just maybe take, in terms of that figure of 90% from the audience, if you either have TS or are a carer for someone with TS, could show of hands for who's dealing with epilepsy, either as a carer or as a patient. So I think we have our 90% figure there. That's pretty good. That's a pretty good approximation, because and maybe another show of hands, how many people are having a form of epilepsy that's difficult to control? In other words, that are not simply controlled on one medication. So that's probably better than, oh well, the hands are slowly going up. So that's also probably to be expected. So more than 50% of those with epilepsy who have TS have difficult to control epilepsy. And the question then is why? Why haven't we got this right? We've all these trials going on. This particular research that Serge was doing is looking at, treating very, very early to try and avoid the long-term consequence of epilepsy. But for people in this audience, we're not dealing with infants necessarily. You're dealing with established epilepsy. And why haven't we done any better with it? Well, that's an interesting question. It's partly to do with the fact that our conception of what epilepsy is kind of limited. We have a view of it as sort of an electrical type disorder in the brain where neurons that are architecturally or structurally abnormal cause little sparks of electricity which can consolidate in the brain and cause seizures. And what we really, the method for treating that hasn't, or at least our conception of how to treat it hasn't changed in 50 or 60 years, maybe even longer than that, where we just give dampeners. We really use medications that dampen down the electrical responses. So we need a new creative approach to treating epilepsy, not just for TS, for everything. There is this medication called everolimus, which is sirolimus, called an mTOR inhibitor, which is a sort of a medicine which is quite different to other anti-epileptic drugs. And it's used in TS to reduce the growth of various tissues like in the kidney and the brain. And that can affect the course of epilepsy. It's modestly good. It's not a miracle cure. If you're having difficulty with your epilepsy, certainly worth trying that. And then the other kind of new drug on the market, I suppose, is CBD oils. And some of you may have been treated with those. Again, if you're having trouble with your epilepsy and you haven't tried that yet, it's certainly worth trying. There is a large trial that I think Elizabeth Thiel ran in Boston, which showed the benefit of CBD oils. And again, why do CBD oils work in epilepsy? That's a good question. I think there are something like 10 proposed different mechanisms. No one really knows why it works, but it certainly does work. But again, there's no miracle cures, and it's really a question of walking through all the possibilities. Has anybody tried CBD oils in the audience? Yeah, so that's good. People have access to it. Or anybody want to try it and can't get access to it? So come and talk to me afterwards, because there is a program the government has created for access to CBD, but I'm aware that in certain parts of the country, some epilepsy clinics don't necessarily know how to do it or have no experience of accessing the government program. So I can help you with that if you're interested. Is there any questions? Yeah, do you want to give a wait till the mic goes up?
Sorry, just going back to infantile epilepsy. So my nephew was at a vocal seizure 6 months, and he's been on vigabatrin, and he's now turning 3. Is there any kind of next steps that we should be looking at in terms of treatment? Because as neurologists, it's kind of like, we'll leave him for a bit longer and then maybe wean him off. Like, what is the recommended, I suppose, next steps for a 3-year-old?
Yeah, and has he gone seizure free on the drug? Is he?
Yeah, we think so. We haven't noticed anything since the first vocal one at 6 months.
Yeah. So the vigabatrin story is really interesting. This drug, it was one of the new generation of anti-epileptic drugs. But it came about in about 1990, and it was a modestly good drug. Like all the drugs we get, it has a certain group of patients that do well on it. It has one significant side effect, which is will cause alteration in vision. okay, and it causes peripheral field loss. Now, what we know about that is if it hasn't happened now, if the child has been on it for a couple of years and their vision is fine, they're not going to get a problem with it. It affects a small number of people due to probably what we call a pharmacogenetic reason. And if you don't get it early, you won't get it at all. So if they haven't had that, then vigabatrin is a safe drug to continue on. You know, one of the maxims we have in the epilepsy clinic is if it ain't broke, don't fix it. You know what I mean? And I think there would be concern about stopping the drug if they think that the child is, because it's a very important developmental time, the age of 3 onwards. My sense is that with every person with epilepsy, not just children, that there's a goal of getting people off medication if they don't need to be on it. Nobody wants, particularly a child, to be treated if they don't need it. So the real value of vigabatrin is to stop those very, very early seizures, which, as Serge's research has shown, when you stop those very early seizures, like the spasms early on, then the cognitive development is preserved for later on. So the first job is done. Vigabatrin has done that job very successfully, so that's great prognostic for the future. I think the question of whether or not to stop the drug now should be based on some kind of personal factors in the child's history. For instance, if the EEG now is completely normal, if the child has no breakthrough seizures, if their development is good, all of those would be built into a plan to consider weaning off the drug. But I wouldn't like to comment, in an individual case without more details. I'll also inoculate my comments by saying I'm not a pediatric neurologist. I deal with adults, so there might be some specific issues around pediatric neurology. I don't know if there's a pediatric.
Can I jump in there? I'm not a pediatric neurologist, but I work closely with them. And
Yeah.
what I can tell you is that in children who maybe have had early epilepsy and no cause is found, and it looks like there's nothing underneath it, pediatric neurologists are often much quicker to remove the drug or wean down the drug. If there's an underlying reason, whether it's a genetic reason of epilepsy or a true sclerosis reason for epilepsy, then they're more likely to continue that because they know there's an underlying reason where they have.
And in TS, like, we're almost certainly talking about some of these tubers, which are structural changes. So I think there'd be a lot of a lot of caution. I suppose one question might be, is there a case to be made to change it to something else? And I think if there's no sign of this visual change, I don't think there is a case to be made. Because, vigabatrin is a fairly well, tolerated drug, and it doesn't have a lot of long-term consequences so long as you don't get the visual changes.
Yeah, I think there was the EEG was normal, everything on his last checkup, and I think it was more so just the neurologist saying, does he need to be on it?
Yeah.
And then the question was they were all saying, because he's grown so much, he's technically weaned himself because his dosage hasn't gone up. So yeah, I think we're just now at that crossroads of whether to push to stay on it or do we look at weaning him?
Yeah. Well, I think some of those factors that Professor Green talked about, if the brain looks clear, the EEG is normal, they might influence it. If there is structural changes on the brain, then that might just, they'd be a bit more cautious. I think, for good reason, there isn't a blanket rule for all of these things, and so each individual case needs to be taken on its merits. And there might be, I wouldn't like to tell you, oh no, you should definitely be off that at this stage. I wouldn't like to say that. Equally, I wouldn't say for definite he needs to stay on it. There would be individual reasons why somebody would stay on it or not.
Perfect, thank you.
Thanks for that overview, actually, for audio. It's very, very helpful. I'm kind of curious. Our daughter is coming up to 3. She would have had infantile spasms, and then the epilepsy was very hard to control for a while. She's on vigabatrin, and then Tegretol was added, and the last 9 months she's much settled down, and we've barely noticed any seizures at all. I guess I have a question. As they approach adulthood, and obviously can't foretell the future, but is there maybe a higher degree of volatility or variability in epilepsy with children with TSC versus maybe the broader population? We feel not a lot more comfortable. We know there's a long road ahead, but I guess how much more volatile is that road maybe if the underlying cause is TSC? Just curious on your thoughts on that.
Yeah, I mean, again, I'm not a pediatrician, so I don't know whether Charlie wants to make a comment about that. But we see children who transition into the adult services really around adolescence, okay, and that is often a volatile time because there's hormonal changes, and the brain is much more plastic. They talk about it being plastic or moldable in childhood, And then once adolescence comes and the hormones come in, you get more concrete changes in the brain. So you sometimes see a kind of a little wobble around adolescence. But in general, my view is that, you know, if you've got stability now, that really is a good predictor for the future, for stability for the future, you know. What's interesting about the tubers is that they are at their most active very early on. This is why the vigabatrin story is so important. Biologically, they are much more active actually in the womb than they are when once you're born. There's a very slow, what we call involution of the tubers. They slowly involute and they sort of develop calcification, calcium accrues, and you know, so they're slowly getting smaller as time goes on. So that's why the early treatment of seizures in TS is so important. So I would say now, you know, without again knowing the individual details of your child's course, that there's very good prognosis for the future if there's a stability now. And I think, you know, because Serge's research is relatively new, it's going to take a few years to know what the implications for these kids who've been well controlled in infancy. What does it mean for the future for them as young people and adults? But I'm optimistic that, you know, because of this kind of biological thing where the tubers are actually kind of shrinking a little bit as time goes by, I think that's going to be a very good prognosis.
Thank you.
Sorry, can I just
Yeah.
Can I just add my tuppence worth there from my experience with vigabatrin when it came in? I remember seeing a study from Paris about vigabatrin and actually infantile spasms in tuberous sclerosis, and the results were outstanding. And I have to say, I feel that the introduction of vigabatrin specifically to treat the infantile spasms was a real breakthrough in the treatment of tuberous sclerosis. And certainly, I think a lot of the pediatricians or pediatric neurologists, if the child's doing well on the drug and they seem to have no side effects, you know, why disturb sleeping dogs, you know, and keep it well. At one stage, a later stage, you may want to move on to other medications. It depends what medications are available. But, you know, the fact is that if you take it off, there's a child is at risk of seizing. And because, as Andrew says, there is an underlying cause, the epilepsy can be very severe. You know, just to keep the child on the medication is a very, very reasonable plan of management.
That's right. I have 2 points to make. The second one of which I suppose is more of a question attached to it. I found that presentation quite emotional, actually, because as the parent of an older person, even with epilepsy, and he's now 33, and looking at, I suppose, the advances of that research and looking at the dates, so, you know, 2012 or whatever, even at the age of 5, took sort of spasms or shakes in her left leg, and she was brought in for an EEG. And obviously this was a long time ago. This was 32, 33 years ago. My recollection is that there was some indication of abnormality, but no follow-up to that. And then at 13 months, she took a serious grand mal seizure, or a series of seizures that went on for several hours and required medical intervention. And following on from that, diagnosed with PS. So obviously listening to that presentation, I wonder if at 5 months there had been some greater sense, you know, could she have had some early treatment, and would that have, you know, a bit of assistance? So I suppose that's just the historic observations that as a parent. The other thing to say, though, in relation to Eden's epilepsy is she, for the first 12 or 13 years of her life, she had maybe only sort of 8 to 10 seizures a year, but they were, you know, status epilepticus seizures that required hospital intervention. So they were, you know, there was a lot of blue light ambulances down to hospitals, and it was a very traumatic period. She has been on anti-epileptic treatment, and she continues to be on daily anti-epileptics, sodium valproate and lamictal, despite the fact that when she was about 14 in 2004, she stopped taking seizures, and for the last 19 years has been seizure-free. She continues to take anti-epileptics. She's also for kidney AMLs on everolimus, I don't know whether that contributes to that. But I suppose the question is, and that's obviously a great relief to us, that her epilepsy is controlled. I suppose, and it maybe relates to the question of the gentleman before me, the fact that she's been seizure-free for 19 years, what optimism should that give us that situation will continue? Is there any sort of research about whether this becomes a lifelong period free of seizures, or must we expect at some point that this is going to revert?
Yeah, that's well, lots of those, the observation and the question. I think that on the first issue, yeah, I mean, it must be amazing if you have an adult child or you are a person with severe epilepsy looking at this research, because it is so groundbreaking and so important. And I think all of us are touched by things which, you know, I had a friend who died only a couple of years ago of cancer, and about a month after she died, they introduced a new treatment which has completely revolutionized that treatment for cancer. So these are things that touch us all, and I suppose medical research is poignant in that regard, even though it provides hope for lots of people. So I appreciate the comment. In relation to the 19 years seizure-free, that's brilliant. You know, I think 19 years is certainly I would feel very comfortable now if I was her doctor telling her that, you know, she can expect a very, very stable future, you know, if she doesn't change her treatment. Now, that doesn't mean you couldn't change treatment, you couldn't come off some of the medication, but it would obviously involve a little bit more risk to do that. And there are actually some very interesting actuarial charts now that have been created, you know, like algorithms where you can feed in the data, type of seizures, you know, medications, previous history, length of seizure freedom, all that sort of stuff. And then it will pop out with a risk of seizure recurrence after 2 years if you were to come off the medication, or risk of seizures after 5 years. And I find this thing of risk. Is there any gamblers in the audience? You know, you don't have to put your hands up, but the gamblers have a totally different view of risk than other people. You know, so if I say to somebody, you know, oh, you've got a 26% chance of being seizure-free, seizures coming back after 2 years, and some people are horrified. Oh my God, 26%, horrified by that risk, and others go, oh, yeah, I can handle that. So people's understanding of what risk is based on lots of different sort of biases and perceptions. So I don't know that we're doing a good job by just giving people a percentage risk. If you're a risk averse type of person, then I would say leave things as they are. The other calculus here is, what are the long-term consequences of the medication? And that's an important question. And now my sense of that is that there might be a strong case to not necessarily come off medication, but change to one that maybe has less negative effects on the body. So for instance, a drug that you might all be familiar with called Tegretol. Some of you will know that drug and be on that drug. So that drug probably in the long term has some consequences for thinning of bones. Okay, so maybe, you know, this is osteoporosis, a very common condition that affects people, women more than men, particularly postmenopausal women. So we probably have 30-40% of people with slight thinning of bones, you know, in their 50s and 60s. You get that happening in the 30s and 40s in people on long-term Tegretol, right? So you're asking the question, you know, is there any option to mitigate that? And actually, the interesting point is there are options. There are newer forms of Tegretol which have less effect on bones. Do you know what I mean? So I think there's a conversation there. You know, first question is, am I happy to take a risk in coming off? If I'm not, if I'm risk averse, if I just say no, I just don't want any. Because I think, like with 19 years seizure freedom, you can be very, very confident that things will go on like that now. Do you know what I mean? You're not expecting a change. Okay, so the only change might be the question of either stopping or changing medication. And stopping medication has its own risks. Changing has a slightly less risk because you're changing something else. There's still a little bit of risk with the change, but obviously less. And so it's a bit of a balancing act. There's a conversation to be had about what are the long-term consequences of this drug. Do you know what the drugs are?
The anti-epileptic drug she's on is sodium valproate and lamotrigine. Okay,
so lamotrigine, you know, for a person in their 30s, very, very safe drug, particularly for a woman. It's the drug. It's one of our premier choices of drugs. Very little effect on kidney or liver function, and really fits in well with reproductive and hormonal health. So that's a great drug. I have people on it for 30 years. I have no concerns about it. Sodium valproate, little bit more of a concern, especially if there's issues about reproductive health. It's the drug you do not want to get pregnant on at all, because about 50% of the offspring of people who are take valproate can have significant anomalies, fetal anomalies, and developmental problems. So we just don't want anybody getting pregnant on that drug. I think apart from that, though, in the 30s, it's a reasonably safe drug. But we now know that sodium valproate is not a drug you want to go into your 50s and 60s on. There are significant issues with regard to movement disorders and can cause kind of Parkinsonian syndrome in later life. So I think there's a decision to be made about sodium valproate in this case. Lamotrigine, I'm happy with. And I again, just on a very, very superficial level, like my sense might be that with 19 years seizure freedom, you could potentially come off the valproate, stay on the lamotrigine. That would be certainly an option with only, I would say, a very small risk of that going wrong, and the positive benefits of being off sodium valproate. So, but again, there might be other factors there. You need to talk to your neurologist about that.
That's really helpful. Yeah.
Yeah, sure.
Hi, how are you? My daughter was seizure free from the age of 3 to 7, and she's 16 now, and we haven't been able to get control for seizures. We've gone through, I'd say, 20 odd drugs at this stage. Is that normal? She was diagnosed at 3 months, and we got seizure free on Lamictal and Rivotril. And as I said, they came back in 2014. We've gone through, I'd say, the majority of drugs now, and she has kidney problems at the moment. So we're going to go on that everolimus thing as well on Monday, but she was on that before. She's also on medical cannabis, and we still can't get her seizure free. She's also moved to the adult section in Limerick for her epilepsy, and he's introduced another drug to her. So as of from Monday, she will be on 4 AEDs, medical cannabis, and everolimus. Is that an overload in her body?
Yeah, I mean, I'd love to, the general principle would be, we should be horrified by having somebody on 6 different medications. I'd love to tell you that I have no patients in my service or like that, but unfortunately, we have a few patients who are on a lot of medications. I think that
Well, she has no existence at the moment. She's sleeping all the time.
Yeah,
and I'm fighting to try and get her off a drug before they introduce another one.
Yeah. No,
so I might as well be talking to myself.
Well, I think you're right, but that's the calculus. So it's if you have a patient who's on 4 or 5 or 6 medications and they're actually functioning, it's harder to it's at least you need to be a little bit braver to make the changes. Now, again, I'd like to think that we do say that. I mean, mostly we would argue that you shouldn't be on any more than 3 medications. There are people in my service definitely on 4, even 5 meds, but if they're functioning, they're getting on with their lives. You can make that argument.
She sleeps.
But if she's not, look, I think that's you just need to say that that can't go on.
Well, I've done it on numerous times now, but we're under a new neurologist, and we met him in April, and he hasn't seen us since. But now that her kidneys are taking effect, that we have to go on this other drug on Monday, then I keep swinging them and saying I want her off one of the AEDs, but they won't touch her. So do I make a decision to take her off with myself as her mother? I can't change it, doctor, because we have no neurologist in Limerick. This is the only neurologist we have. We've been without a neurologist for nearly 2 years. Yeah. Because with COVID and transitioning from Crumlin to Limerick.
Yeah. Okay. Come and talk to me afterwards. We'll talk about a strategy.
Just a couple of quick ones. I'm not sure I'm going to have quick answers, but they're quick questions. Have you heard of I was reading a couple of papers just about the efficiency of metformin, which is a diabetes drug, as an alternative to an inhibitor of the mTOR pathway, and the results seem to be pretty good for that, and it would be cheap. It's easily available, probably made locally, would be a great alternative if the results for that turned out to be useful. So I just wondered if any of you heard about that as an alternative.
I haven't heard about metformin. I mean,
the metformin theory is dead. It was put forward at one chat as it might have been a sort of an alternative to the mTOR pathway, but it's died a death.
So the results are
overtaken by
positive for that?
everolimus and serolimus, and
Yeah.
what we were hearing about yesterday, and you'll hear about it later on today. But
Okay.
no, it's a very good point. It was raised at one stage as a thing, and as you say, it's a cheap drug.
Yeah.
Very few side effects, but I'm afraid no good.
Okay. And the other quick one then was the presentation, which I really struggled with as well. I thought it was very interesting. One of the questions it raised for me was just in relation to kind of causation in terms of developmental pathway. It raised the point for me that when I suppose we've got our diagnosis, well, initially, your 20-week prenatal scan, you can see the cardiac rhabdomyomas, but subsequently after birth, after a few months, then you get the genetic analysis and confirmation. And the geneticist pretty much said, I can be 100% sure that the level of kind of cognitive dysfunction and intellectual disability will be quite severe, simply based on the genetic profile. And it turns out he was pretty accurate. So the question in relation to, epilepsy and causation for a level of intellectual disability, how far back can you go, and what are the different kind of co-occurring conditions associated with tuberous sclerosis that you can look at and intervene with to determine the developmental pathway? Like epilepsy is one of the things that if you can control, obviously quality of life and developmental pathway improves, but can you go back even further than that, look at a genetic profile and say, well, if we intervene at this point, even before, the potential epilepsies or UCUs in the big background or whatever, can we intervene further back in the pathway and improve quality of life and outcomes for individuals by looking at that?
Yeah. Well, I maybe you want to comment on this, Andrew, but I mean, I assume that the doctor was talking about the difference in TSC1 and TSC2. TSC2 is typically
also the nature of the specific mutations itself and how that profile looked. It wasn't just the location; it was the specific nature of the mutations.
I don't know that kind of fine-grained based on the mutation will give you that kind of an answer.
Yeah, I'm coming on my Colin. But so my other hat is I'm a geneticist, and in terms of tuberous sclerosis, TSC2 gene alterations are more common than TSC1, and people who have a TSC2 gene alteration tend, on average, to have a more severe form of the condition. Most of the changes in the TSC2 gene just stop the gene working. So however the gene is stopped working, whatever gene alteration that may be specific to that person, and stops the gene alteration, stops the gene working, then you just don't have any TSC2 protein. So you can't really infer from a TSC2 change, the specific one, to say that this is worse than any other TSC2 alteration. There is one exception when there are a very small number of children who have a big chunk of DNA missing that takes out both the TSC2 gene and a polycystic kidney disease gene. That's a very specific case. It's only about 5% of people with tuberous sclerosis. Outside of that, you can say that TSC2 related tuberous sclerosis is more severe than TSC1, but not specifically on the mutation.
Yeah, and I think obviously I don't know when you got that news or that discussion happened, but I mean, Sergio's data really is showing how dynamic the changes are and how important the early seizures are in the development of the intellectual disability. Do you know what I mean? So I think that's probably something that we didn't know until he did the research. Maybe people suspected it, and famously, in the 1890s, Gower, who was like one of the fathers of epileptology, said that if he had a metric around it, if he had more than 100 convulsions, that usually correlated with the development of cognitive changes. So we've known that epilepsy, can cause cognitive changes and developmental problems in children, but this was the clear evidence. And actually, the startling thing, of course, was, and what he's trying to make the case for now, is treating even before the seizures start. You know what I mean? Just when the EEG is abnormal. That's what the whole regular EEGs are for. And, unfortunately, that's coming very late for people with adult children or adolescent children. That's too late. But for the kids now who are just born and have had the benefit of that research, it's great.
Just 1 point, 20 years ago, vigabatrin would not have been easily available.
No. In fact, the vigabatrin story, because of the visual changes, Elizabeth Teals, who some of you know, is a famous epileptologist who works in Boston. And when I was training there with her patients had to go over the border to Canada to get the drug. The drug was banned by the FDA because of the side effect. They thought it was, despite the fact that they reckoned it was a good anti-epileptic drug, that the visual changes were not enough. And so, but we knew that this had to be done. And so people go across the border into Canada to get the drug.
If it's a.
Was it banned? It might have been banned here for a period of time. I don't think it was ever banned outright here, but.
Like our diagnosis was about 9 years ago. So a couple of months after her daughter was born, she started infantile spasms, put on Vigabatrin and controlled them
Great.
continuously for a couple of years. And then because of that suspicion for peripheral vision loss,
It was
wean
banned.
her off that.
It was banned in the sense that it wasn't allowed to use for any other forms of epilepsy, but the response to infantile spasms was so good that people felt that the benefits of giving the Vigabatrin outweighed the risks of peripheral vision problems.
Yes.
And it was still used. And I mean, I can quote you, even in my small practice with epilepsy around Craigavon, you know, children that really did very well. We got the seizures under control very quickly. And my personal theory is that we did stop a lot of the intellectual problems with it by getting the seizures under control. It's called the theory of kindling. I don't know whether that term is still used nowadays, but certainly in early seizures and tuberous sclerosis, kindling does occur.
Yes.
Anyway, listen, we're going to move on. And thank you.
Can I just say one thing about epilepsy treatment? I find there's one question there as well.
Yeah.
And I have one comment to make. We'll take the question first.
I actually have tuberous sclerosis myself. I'm 39, and in my experience, diet is key. Too much sugary foods causes seizure. Or carbohydrates.
Yeah. So remarkably, that was the comment. That was the last comment I was going to make. I was going to talk about diet as a treatment option for epilepsy. So, I mean, I think in general, the general principle that you would have a low or no sugar diet and low carbohydrates, you know, seems reasonably easy to project out that to you know, parents and people who have control on what they eat. There's a much stricter form of the diet called the ketogenic diet you might have heard of. And that is a diet that does require a more observation, supervision by a qualified dietitian. So we have one in James's Hospital, who's the only one in the country. She's the senior specialist dietitian, Laura Healy. And it's really an option that really should be much more available than it is. And I've been making the argument about diet since I started epilepsy care years ago. And I had to fight to get the one dietitian in James's. I'm not sure how we unfortunately the dietary story, and I'm delighted you brought it up, is not one that's either well understood or endorsed by a lot of specialist neurologists. That's the problem, right? So if we all agreed, you know, that we needed 6, you know, dietitians around the country to deliver the ketogenic diet, then that would be one thing, and we'd have to fight our corner with the government and all the rest of it. But actually, unfortunately, we don't have that agreement. The pediatric neurologists are a little bit more on side with this, but you know, we did a survey last year of the adult neurologists' attitude to dietary changes, and you know, they were a bit lukewarm about it. You know, and given a choice about services, if we said to them, "Look, you can have a dietitian for your epilepsy service, or you can have, you know, another EEG technician," they would take the EEG technician. Do you know what I mean? So I think it's really up to you guys in the places you live and to start demanding it, especially when you're down to 6 different medicines. You know, you've tried the diet, okay?
Actually, if you take sugary foods within 2 hours before bedtime, you're guaranteed it's
Yeah, now some people can relate it to that. For those who are interested in trying, you know, a kind of self-management program, the diet that Elizabeth Teal used as an alternative to the ketogenic diet was what's called the low glycemic index diet, which is something you can do at home. It's the sort of diet that the celebrities in Hollywood use to lose weight. It used to be called the South Beach diet. I think Jennifer Aniston used it. But it is a low carbohydrate diet, and there is the hazard of possibly losing weight with it. You have to be careful if you're underweight, that you want to be careful about that. But it is certainly a diet that could be done at home. You can buy the what's called the GI diet in a local bookshop. It'll say nothing about epilepsy in it, but if you follow the principles of the GI diet, you might find that it's very beneficial for your epilepsy.
Just one more thing: if you're feeling a threat of taking seizures, dance music can trigger seizures.
Say that again.
Dance music
can trigger seizures. Okay.
Now, I know this wouldn't be the case for everybody.
Yeah. I mean, I would, yeah, exactly. I wouldn't say that's a general statement. It might relate to you know, where the epilepsy is generated, for instance. Yeah, I wouldn't want to put off everyone off dance music. There may be benefits to dance music that are also helping epilepsy.
Completely random, but just, you know, just.
Yes.
Yeah.
Sure. Okay.
Thank you very much indeed, Colin. Thank you very much indeed for all your comments and discussion. Just to point out that Epilepsy Ireland has a desk out in the foyer just at the canteen, and it's got all good material to advise you about problems with epilepsy, and we will be touching on the subject of epilepsy later on this afternoon. Anyway, we're moving on to have Andrew again. Andrew is better known as the Professor of Genetics at University College Dublin and the Senior Geneticist out at Crumlin Hospital. And his background consists of time in Cambridge, where he helped to identify the 2 genes responsible for tuberous sclerosis. So he's an undoubted expert in his field. Andrew, thank you very much indeed.
Thank you very much, Charlie. So yes, thank you very much, and thank you all for coming. I know a lot of people find genetics complex and difficult to get their head around, so I'm going to try and keep it as simple as I can, and I'm obviously happy to answer questions afterwards. I'm going to go through this step by step. I'm going to give you a background on some of basic genetics. I'm going to talk about a bit of how we got to the tuberous sclerosis genes, what they do in a fairly practical way. I'm going to talk about the practicalities of genetic testing. I'm also going to talk about genetic counselling and the family implications for tuberous sclerosis, which are essentially you can call reproductive options at that stage. So the concept of gene has actually been around for a very long time, although the word was only coined in the late 19th century. It's a particular inherited element which gives a person a particular trait. And it's been known for thousands of years that particular characteristics then may run in families. If you can read hieroglyphics, I can't. The Egyptians, pharaohs, actually, there was descriptions of particular characteristics that were transferred through the pharaohs' families, so they knew about it even then. And that's been known for a very long time. It also has a slightly different definition, which is looking at the biology side of it. So a gene can also be said to be a part of the stretch of DNA, deoxyribonucleic acid, which encodes for a particular protein in a cell in the body. We all have about 20,000 or so genes in every cell in our body. We have them from the moment we're conceived. They don't normally change. And we have 2 of every gene, one from our mother, one from our father. And then that's why we're always half our parents. You can get long arguments about whether he looks more like his mother and more like his father, but I'm afraid you're still just half and half. But it makes for an awful lot of conversations. And these genes come in random lists, which are called chromosomes. Chromosomes are simply long strands of DNA containing those genes. And those chromosomes are inside the cell of everybody's cells. We have billions of cells in our body. Inside the cell is a clump called a nucleus, and that contains those chromosomes. And you can analyze chromosomes. That was the first kind of genetic testing that was done, which actually started in the late 1950s, early 1960s. And we have 23 pairs of these chromosomes. And so you can actually take cells from people and from their blood, look at them down the microscope, and you can see these chromosomes. These are cut out pictures of these chromosomes. They don't look like this down the microscope. And we have pairs of chromosomes, 2 1s, 2 2s, so on, down to 22. Here's chromosome 9, or at the very bottom of that, there's a tuberous sclerosis gene at the bottom of this one, and another one here. And this is chromosome 16, and there are tuberous sclerosis 2 gene is the very tip of chromosome 16 here, and tip of chromosome 16 here. I'm not telling you I can see it. There's different technology we use to try and actually see it. And this is a chromosome pattern of a woman. It's female. She has 2 X chromosomes. Men have the same chromosome pattern, except they have an X chromosome. They only have 1 X chromosome, and they're different to small Y chromosome. So if you actually count up the amount of genetic material, you'll find that there's more in every cell in a woman than there is in a man. But I suppose we knew we were inferior anyway, so that probably doesn't make any difference. And these chromosomes are made up of a mixture of proteins, and the DNA is tightly wrapped in coils in these chromosomes. And those coils, then if you unwind them, eventually turn into the very famous double helix that Crick and Watson described back in the 50s in Cambridge. And they contain a code, which is made up of 4 letters, A, T, G, and C. And they act as a code whereby that code of DNA is transcribed into stuff called RNA, and then eventually that is translated into proteins. So the proteins we find in every cell in our body actually are made up according to the code that is encoded by this DNA. And there are 3 billion bits of DNA in our genome. It's actually quite like a computer code. If you think of computer codes, you basically have two options. You've got a switch that's on or off, so 1 or 0 in mathematical terms. And that's the entire code that you use to drive your mobile phone, the computer that we're all trying to work. Excuse me. And it's the same principle, except that a DNA code is more complex, 4 times more complex, because you've got many more options of a code. So you get more information packed into DNA than you can into a computer. But that is what we all have to encode all of our proteins and drive how we develop, drive how our cells work in our body and our everyday body functions. And this is the DNA double helix. I'm not going to go through it all in detail again. You've got the 4 code letters A, T, C, and G. The whole DNA imagery has been taken and used in the media in lots of different ways. And people talk about things like hurling being the DNA of Kilkenny, or whatever the local term is. It's getting carried away. And it's gone to extremes. You can actually now buy perfume, which is called DNA. Actually, the A stands for acid. So if you are getting a perfume, it's actually just acid. Not very helpful for you. And of course, the DNA is actually the same in terms of the structure in both males and females. So you can get DNA in your beers. And if you want to, your kids can buy a CSI DNA laboratory to play with at home. And this is a really extreme one. British company Jaguar were selling a new model of car, and they were trying to tell you that, I'm quoting them, they had 2 cars with the one DNA. Now, cars don't have DNA. And they actually managed to drive them down a beach in West Wales to make a double helix out of it, to show you that Jaguar is genetic, which it isn't. So the DNA imagery gets seriously out of hand, but that's what we all have to live with. Actually, in terms of DNA, we have changes in our DNA, what used to be called mutations, and are now known as pathogenic variants. And in most situations, the protein works. The translation system for making DNA, the code to produce a protein that works fine. But sometimes you can have an alteration in the DNA that stops the protein being made, or if the protein is made, it doesn't work, it doesn't do its job properly. And those are often called mutations or pathogenic variants. But you can also get changes in your DNA, where you've got a subtle change. You can see here, there's a different one here from over here. And it actually gives you a slightly different protein. It's a different amino acid in the protein, but actually it doesn't change how the protein does its job. So that's known as a benign genetic variant. And we have lots of those as well. And actually, we also have gray areas in between, where there may be a change in the DNA that makes some kind of change in the protein, and we're not sure what the effect might be on whether that protein works or not. And we have lots and lots of human variation. Nobody is normal. We all have about 5 million variants. Many of them alter the DNA protein. Many of them stop the protein working. A lot of them are new genetic events. So we all have our own unique genetic pattern. And in all our DNA, we will find lots of changes that might be significant, but in fact, many of them are not. So how does that all impact on tuberous sclerosis? Well, tuberous sclerosis is an autosomal dominant condition. I'll explain that in a minute. It's also known as fully penetrant, which means is that if you have a significant alteration in one or other of the tuberous sclerosis, your 2 copies of the tuberous sclerosis gene, you will show the condition. But it shows variable expression or expressivity, which means that even though you may always show the condition if you have a gene change or a significant gene change, you may have mild effects, but other people in your family may have severe effects. And there also can be differences between families, not just between members of the same family. And about 2/3 of the time, that specific genetic change in one or other of the tuberous sclerosis genes starts as a new genetic event, also known as de novo from the Greek, the Latin. And it used to be thought of as a really rare disease. Technically, a rare disease is something that happens less frequently than 1 in 2,000 of the population. Tuberous sclerosis is still about 1 in 6,000, 1 in 10,000. And as Colin was saying, there's probably about, if you do the sums, that's probably about 700 people in Ireland with tuberous sclerosis. We don't have anything like that number on our books. We have several hundred, but not 700. And there are still many more people out there with tuberous sclerosis, some of them who may know they have tuberous sclerosis, but some of them may not. There may be people who've got intellectual disability and seizures who are in residential care who've never actually been diagnosed, even as adults. And as on an autosomal dominant condition, that means that an alteration in one of your two copies of a gene is sufficient to cause the condition. So people who are affected by the condition have one normal tuberous sclerosis gene, one that doesn't work. The large D represents the one that doesn't work. The small d represents the one that does work. And if you assume that the person who has tuberous sclerosis, their partner doesn't have it and are otherwise healthy well, they have two normal tuberous sclerosis genes. When they're having their kids, they can either pass on the small gene, the gene that works, in which case you've got a healthy daughter or a healthy son who's quote, quote, normal, or you may have a child who inherits the altered gene, either a boy or girl, and they would be affected to some degree, which means there's a 50-50 chance for each child of a person who has tuberous sclerosis of that child also having tuberous sclerosis. And it doesn't matter how many other kids in the family have it or don't have it. It doesn't matter what order it happens. It's still a toss-up, a 50-50 each time. And that's back to the points that Colin was making about risk. Chance doesn't have any memory. The numbers that came up that you won in the lotto last week could just as easily come up this week or next week's lotto. It's a completely random event. What about the history of tuberous sclerosis genetics? This is going back 30 years. We didn't have mobile phones much. If they did, they didn't work very well, but you might be able to text. There was no internet. There was no DNA sequence known. The Human Genome Project wasn't set up. Computers were pretty limited. There was no touch screens, if you remember back that. Maybe you don't remember that far. So despite those limitations and actually very limited amount of genetic technology, it was possible to identify both of the tuberous sclerosis genes. And it's actually 30 years since the first of the tuberous sclerosis genes, which happens to be the TSC2 gene, identified by a consortium. And again, European collaborations were really important in identifying these genes. The chromosome 16 was found by a group from Oxford, Cambridge, and the Netherlands, Julian Sampson, Dickie Halley, and Pete Harris. And that was an enormous success to be able to do that. And then a couple of years later, I was involved with the group along with Sergiusz, who isn't here, which was a collaboration between the Netherlands, Cardiff, the US, Cambridge, to identify the tuberous sclerosis gene on chromosome 9q34. And that introduced genetic testing for tuberous sclerosis. And once those genes were identified, genetic testing for families with the condition came in pretty quickly. And now it's very much a standard process of the management of families with tuberous sclerosis. So there are definitely just two tuberous sclerosis genes. And the TSC1 gene is a stretch of DNA that encodes a protein. And the protein for the TSC1 gene is called hamartin because of the hamartomas that are described as the changes you see in the brain in the cortical tumors in people with tuberous sclerosis. And the TSC2 gene is a protein product called tuberin. The two bits of protein work with each other. They combine together to do the same job, which is actually to damp down cell growth, which is triggered through a pathway which is known as the mammalian targeted rapamycin mTOR. And if you lose either the TSC1 protein or the TSC2 protein, that damping mechanism doesn't work, and cells tend to proliferate too quickly and grow too quickly and develop into the benign growths that can happen in people with tuberous sclerosis. So the tuberous sclerosis genes are known as tumor suppressor genes. And I like to think of them as what you have in your car. You've got a handbrake. You've also got a foot brake. And they tend to slow the car down. In the cell, the same braking mechanism works. The tumor suppressor genes slow cells from growing too fast. But if you have an alteration in one of those genes, in either one of the tuberous sclerosis 1 or the tuberous sclerosis 2 genes, you're susceptible to developing something, but nothing actually happens if there's only one gene altered in the cell. Similarly, if you lose your foot brake, you still got your handbrake to stop your car. But if you get a second alteration in the other copy of either the TSC1 or the TSC2 gene, you lose it, it stops working in some way, then there's no braking mechanism, nothing to slow the cell to go growing, and you get excessive growth. Or if you're driving a car, you have no means of stopping it because you've lost both your foot brake and your handbrake, and you get uncontrolled acceleration. And that's the mechanisms are described going with tumor suppressor genes. And in people with tuberous sclerosis, the first hit happens is something they have in every cell in their body. It's in the germline. But the second hit may only happen in some particular cells. So it might happen in a kidney cell to cause a benign kidney tumor, the angiomyolipomas. It might happen in the heart to cause the benign tumors that occur in the heart, which are known as rhabdomyomas. So that's something specific to the tissues and cells in the heart or the kidney or the brain. And here's an example. This is from a paper from a very good scientific paper describing tuberous sclerosis by Chris is obviously here, Sergiusz Jóźwiak that I worked with in his deal in Boston, who Colin worked with. And you get an alteration in the TSC gene that's inherited. And if you get a second hit in different organs, you can get the benign kidney tumors, you can get the lung changes, lymphangiomatosis, or the skin changes, the angiofibromas on the face. But occasionally, there will be people who actually have normal tuberous sclerosis genes in almost all the cells in their body. But occasionally you can get a second hit, a first hit that just happens in one specific cell. And just by chance, you also get a second hit in the same cell. So sometimes you get people who just have a single kidney tumor, benign kidney tumor, or angiomyolipoma, or specifically the lung change in specific cells, but not in the rest of the body. That's known as a somatic pathogenic variant. This is the cell signaling pathway that involves mTOR. I'm not going to describe all of that to you. The role of the mTOR pathway is to take signals from the outside of the cell and transmit them to drive cell growth. And part of the role of tuberous sclerosis here, the TSC2 and TSC1 genes, is to damp down that activity of this mTOR protein. And if you lose that, then you develop tuberous sclerosis. Interestingly, there are related conditions that actually also act, genetic conditions that also act through the same pathway, conditions called neurofibromatosis 1 and 2, both of which are also involved in the mTOR pathway. And rapamycin, or everolimus, the drug that quite a number of people are now on that's been effective, in a way replaces what tuberous sclerosis proteins should be doing by independently damping down the growth of the mTOR, growth of cells driven by uncontrolled mTOR activity. So when you're looking at genetic testing for people with tuberous sclerosis, there are 3 types of changes that are significant, known as pathogenic variants in the tuberous sclerosis genes. In the tuberous sclerosis 1 gene, that's the lesser common of the 2 genes which are altered. So about 20 to 30% of patients who have tuberous sclerosis have alterations in this gene. Again, they're usually loss of function, so they actually cause stop the protein from working. But it tends to be a milder condition on average if you add all of the patients. And in fact, it's more commonly inherited. Whereas in TSC2, which is the gene that's more frequently altered in about 65% of patients, it tends to be associated with more significant disease. Again, you can have lots of function variants. It's also something that more commonly occurs as a new genetic event in the child. It's not something you may see in the parents. But there are some specific variants in the TSC2 gene, about 3 or 4 of them, that are associated with milder disease. And then there's a very rare form, which was actually only identified after the polycystic kidney gene was found on chromosome 16 to sit right beside the tuberous sclerosis gene. The 2 of them sit together. Polycystic kidney disease is a relatively common genetic condition. It's not a rare disease, which causes the development of lots of cysts in the kidneys, and people with polycystic kidney disease get progressive kidney failure and may end up needing dialysis when you're in your 40s and 50s. But they don't have any other brain involvement apart from occasionally some aneurysms and sometimes some cysts in the liver. But there are a small number of people with a combination of tuberous sclerosis and polycystic kidney disease where they've actually had the 2 copies of the gene taken out, both genes sit beside each other, and there's a large deletion which takes out both copies of the gene. You still have 1 copy of the TSC2 gene and 1 copy of the PKT1 gene left, but you actually got the effects of both of those genes. And that causes not just tuberous sclerosis too, but also cystic kidney disease in childhood. I'm only aware of about 3 or 4 Irish children with this condition. Is a rare form. And it's usually genetically a new genetic event. And occasionally it can be mosaic, slightly milder. It's important to realize that genetic testing for tuberous sclerosis is not essential to make the diagnosis of tuberous sclerosis. There are good guidelines. This is the updated versions. They've been out since 2012 with the previous ones. And the first author of that is Hope Northrup, who's an old colleague of mine from California. And they have very clear criteria for the various problems, whether it's the skin tumors or the heart tumors or the subappendylar giant cell astrocytoma, also known as the SEGA, that you need to have two of those major criteria or one major criteria and several minor criteria to make the diagnosis of tuberous sclerosis. I'm regularly referred to people who clearly have fulfilled these diagnostic criteria, saying, please do genetic testing on this person because we think they have tuberous sclerosis. They actually already have tuberous sclerosis based on their clinical criteria, but we can still go ahead and do genetic testing. But the genetic testing is not going to decide whether it's tuberous sclerosis or not. The same guidelines say that identification of genetic changes in the TSC1 or TSC2 gene is sufficient also for the diagnosis. And certainly for the family reasons, or for these classification of the severity of the condition, we would do genetic testing. And it also really helps for advising the family. So when I'm talking to doctors who are seeing patients who may think they have tuberous sclerosis and they're doing diagnostic testing, I explain to them that it's really important that you discuss this with either the person themselves or the parents of the child where there's concern over tuberous sclerosis to make sure that they give informed consent. There's actually a legal requirement in Ireland for informed consent for genetic testing. But in doing that, explain to them what the condition might mean if it was going to show up a change in the TSC1 or TSC2 gene, and what that might mean not just for the child, but for the family. There is specific genetic testing that needs to be done. It's called NGS sequencing and looking for gene dosage. They need to do it in a diagnostic lab, which is an appropriately qualified lab, which is usually appropriate. It's also important for families and doctors to realize that genetic testing takes longer. If you go and get a blood test to see whether you're anemic or not, you get the results in 4 hours. Genetic testing can usually take somewhere around a month or two, depending on the complexity of the test. And that would be the normal standard. So there's a time scale. And I also emphasize to doctors, if you're doing those kind of tests and it's going to take a month or two to come back, you need to plan with your family how you're going to give them results. Tell them roughly when it's going to be there. Do they want to get a letter? Do they want to meet up at the clinic? Do you want to have a phone call? And how it's going to work? So plan ahead for that. One of the difficulties with tuberous sclerosis genetic testing is that our ability to understand the changes in DNA has got more complex. There's very much perception out there that genetic testing gives you a yes or no answer. It's always black and white, cut and dried. There's no fuzzy edges. There's nothing difficult in the middle. But in fact, with more and more genetic testing, it's now clear that you can get grades of genetic changes, which can vary from benign variants, which don't report, those that are clearly causative, known as pathogenic variants. And sometimes you can get a change in a DNA sequence that you're just not sure what it means. It's called a variant of uncertain, not unknown, but just uncertain significance. And so when people get results from tuberous sclerosis genetic testing, first of all, it may show, if there's somebody who has some clinical signs of the condition, that they have a variant that is pathogenic, a change in one of their two copies of either the TSC1 or TSC2 gene that says, yes, this is tuberous sclerosis. And that's clear cut. And that's a help for some families. It may be also very difficult to deal with, but it certainly may give some clarity. You may also get a result which says no gene change has been identified in either the TSC2 or TSC1 genes. However, we know that maybe 90% of people with tuberous sclerosis will have a genetic change detected, but there's another 10% of people who still have tuberous sclerosis, which you can't identify using current technology what the specific gene change is. So a normal result in somebody who has clinical signs of tuberous sclerosis, who fulfills the clinical criteria, does not exclude tuberous sclerosis. It simply means you haven't been able to find the cause for it. But it could be also what's known as mosaic tuberous sclerosis. You may also get a result which says there's a variant of uncertain significance identified, one that you don't know quite what it means. That is not the same as a diagnostic result. It simply means you can't use it in a clinical setting to make clinical decisions to say somebody does or doesn't have tuberous sclerosis. Sometimes you can do further investigations tracking that variant through a family or doing additional studies on cells or RNAs. But that's very much at a research level. You may be able to investigate that further. So you can get 3 possible results from this. What about genetic counselling? A lot of people get spooked by genetic counselling because it's thought that was something that you have to go and lie down on a couch and reveal your innermost secrets to a counsellor, whether you want to or not. That's not genetic counselling. We have currently there are about 14 or 15 genetic counsellors in the Republic of Ireland as a whole. There should be about 50. And those genetic counsellors define what they do as a communication process dealing with the human problems associated with the occurrence, if a condition has happened, or the risk of occurrence, the likelihood of something happening again for a genetic condition in the family. And it goes through helping people understand the medical facts about the condition, diagnosis, what the nature of the condition might be and how it might develop, and what management there is. And also go through the hereditary factors about the condition and what it means, not just for the person in front of them, but also for the wider family. Understand what options they may have for dealing with the risk of recurrence, including choices about future family. And then choose whatever the course of action is appropriate, not for the genetic counsellor, not for the doctor, but actually for the family themselves. And then back them for whatever the genetic counsellor will back them and support them in whatever decision they make. And then make the best possible adjustments to disorder, which often is a very tall order for a lot of families dealing with difficult genetic conditions. So essentially there's four elements: the medical facts, going through the genetic elements, and then tying that together about all of that and how it might impact on a family. And our genetic counsellors will often provide detailed letters, information about the condition if there is appropriate leaflets, and there are good leaflets from the UK Tuberous Sclerosis Association, both for patients, families, and for GPs about managing the condition. And also if there are support groups for the condition, and there obviously is the TSC Ireland here, which is I'm very glad to support, providing information so that people get in contact with other people who have the same condition, to share experiences, to share information, rather than just leaving them on their own. Because often if you're diagnosed with a rare condition, it can feel very isolating, and it's important to know that actually there are other people out there who've been through what you've been through. So what about choices in terms of having further family or not? And this is a list of 8 options for an adult who has tuberous sclerosis if they're thinking about having a family, and the specific genetic change that's caused the condition then has been identified. And once you see a list of 8 different conditions, you realize that actually there isn't a right answer for everybody. There's a choice of things for any people to choose. And again, it's their choice, not the doctor's. They get the information, discuss it together, and make whatever decision they choose as to being the right one. And some people maybe consider, if they've already had a child with the condition, to have no further children, because maybe involved in the care of a child and they haven't perhaps the time to devote for a second child, whether they do or don't have it. Others may choose the same 50-50 chance we talked about of having an affected child and go ahead, get pregnant and wait to see what happens. Others may choose getting pregnant and having a genetic test during the pregnancy, prenatal diagnosis, looking for this tuberous sclerosis gene alteration known to be present in the family. Others may consider not doing a genetic test in the pregnancy, but actually having a detailed ultrasound and potentially MRI scan of a baby's brain or kidneys during the pregnancy. If it's a man who's affected with tuberous sclerosis, then there's a choice of getting pregnant using a donor sperm. The sperm donors are screened for medical conditions and have basic genetic testing, which have to be all normal, as well as to check for infectious diseases. The donors come from Europe. There aren't any Irish donor banks. It's something I know some people choose. However, they do need to realise, obviously, that the child who is conceived by sperm donation is not going to be the biological child of the man who is raising them. And that raises issues of whether you do or don't tell that child in time and what time you might do that. Some people choose to adopt. However, there are very few children in Ireland available for adoption, and international adoptions have been quite difficult. And again, there may be issues in relation to the adoption agency considering somebody who has an underlying medical condition as a potential parent for an adopted child. Some people may consider what's called pre-implantation genetic diagnosis, testing of embryos genetic testing of embryos made by IVF, and I'll talk about more of that, or about non-invasive prenatal diagnosis. So this is the technology for testing during pregnancy of an established pregnancy. It's called a chorion phyllis sample, taking tissue from the placenta at around 11 or 12 weeks. The placenta contains the same genes as the fetus. It does carry a risk of miscarriage, about 1 or 2%, and it would be tested. That sample would be tested for the tuberous sclerosis gene alteration, and a couple would then get the result back, usually in about 2 weeks from the time of the test, sometimes earlier. There's also a later test, which is called amniocentesis, which is taking fluid from the surrounding baby containing cells that come from the fetus. If done around 15 or 16 weeks, it has a lower miscarriage risk. It can sometimes take a longer time, up to 4 weeks, to get a result. For those who want to know. For those who don't want to know, it may not be their choice. Pre-implantation genetic diagnosis is something that's been around for many years. There are 2 clinics in Ireland that provide that. And it's a form of in vitro fertilization, which is originally designed for couples who have difficulty conceiving spontaneously. And a woman is given a lot of hormones on her monthly cycle to produce lots of eggs rather than just the one egg on a monthly cycle. And those eggs are removed from her and then fertilized by her partner's sperm in what used to be called that test tube baby. I don't think they use that term anymore. And if there are embryos produced, they're then put back in the woman's womb with the aim of getting her pregnant. But there is an extra step that can be done, that when an embryo is generated, it's possible to remove cells from the embryo. Here's a blown up microscope photograph of an embryo here, a human embryo with 2 cells being taken away, and they'd be tested for the genetic condition that was known to be in the family, and only place back in the womb those that are not found to have the genetic condition seem to be okay, if you can find that. And those that are found to have the gene alteration will not be implanted and will be discarded. It sounds great. It's actually a significant toll, both physically and emotionally, on the family. It has about a 30 to 40% success rate. And currently it's not actually funded by the Irish HSE, and it costs about 13 grand euros a go. The Irish Health Services HSE is currently considering whether they should fund this or not. I haven't got any news on that at the moment, but I wouldn't hold my breath on that one. There's also a more recent genetic testing method, which is called non-invasive prenatal diagnosis. When a woman is pregnant, obviously what circulates in her blood is mostly her blood, but there is a really small amount of DNA that comes from the placenta of her pregnancy that actually can be found, fetal DNA, circulating in the mother's blood. And it's possible to find that fetal DNA using new technologies and test it for a variety of things in the fetus. It was originally tested for things like rhesus and also for chromosome disorders, but it's now possible to test for specific single gene disorders. And it can be done on about 10 to 20 mils of a mother's blood, not a large amount, and it doesn't carry any risk to the pregnancy. And it can be done at around 9 weeks of gestation. It's been done for cystic fibrosis, spinal muscular atrophy, muscular dystrophy, but it's also being carried out for tuberculosis for those who want it. And then they usually get a result before 12 weeks, which is obviously relevant in the Irish legal situation if a couple choose not to continue with the pregnancy. So those are the issues for reproductive choices. However, quite a lot of the time, people have a child who has a de novo form of tuberculosis. They know what the genetic change is in the child. The parent's blood has been tested, and there's no evidence of the tuberculosis gene variant in the parents. And then the parents will be told, then that's de novo, that's a new genetic event in your child. But actually, the likelihood of another child having the condition is still there, despite the fact that both parents' testing is normal. We said that the frequency of tuberculosis in the population is somewhere around 1 in 6,000. So why isn't the chance of happening again 1 in 6,000? Well, actually, there is a reason. There's a rare genetic phenomenon which is called gonadal or germline mosaicism, which is when some people have 2 different cell lines, with one of which has a specific gene change in it. And in that situation, it can be a mom whose ovaries may have just the tuberculosis gene alteration, but the rest of her is fine. But it does mean that she could produce more eggs with the same tuberculosis gene alteration. Or for a dad, it could be the sperm that he has, number of that sperm, just because the testis has the tuberculosis alteration, but a number of those sperm could actually have the same gene alteration, and there's a chance of having more children with the condition. And that's known as gonadal or germline mosaicism. The first case for this was actually written up 6 years ago by about an Irish family. We wrote that up many years ago. So it is a real phenomenon. This was an Irish family where there were 8 children and 3 of them were affected and neither parent had it. And that was because the mother was a gonadal mosaic for the condition. So it does happen, which means therefore that there is a slightly higher chance of having another affected child, even when parents' chests are normal. And the reproductive choices for parents of a child with apparently de novo tuberculosis are similar that I talked about before. You could have no further children. You could choose to take the 3 to 5% chance of another affected child. And again, genetic testing of pregnancy is possible. You could have scans done, either by ultrasound or MRI when you're pregnant. Genetic testing of embryos is possible by pre-implantation diagnosis, but some clinics who run that may say that this is too low a risk for them to take it on, so it varies from clinic to clinic. And genetic testing of a mother's blood during pregnancy, non-invasive prenatal diagnosis for the tuberous sclerosis gene may be possible as well. And again, those are options for each couple to consider themselves, not to be told what to do either by a genetic counsellor or a doctor or anybody else. So I've gone through tuberous sclerosis. I've talked about the genetics, the biology, the practicalities, reproductive options. I should also obviously mention Tuberous Sclerosis Complex Ireland. You will all see lots of t-shirts and lots of people wearing them, and it's great to see this group of people coming together. We've had various attempts over the last 30 years of getting tuberous sclerosis families together, and this is by far the most successful one. Well done to everybody for doing that. So thank you very much for your attention, and I'm happy to take questions.
Right, thank you very much indeed, Andrew. Just quickly, we'll take any questions.
Not afraid to get people do you have brain involvement to the brain? The question, would this mean that a different prognosis was further?
No,
No.
not necessarily. Prognosis is really going to be dictated much more by what her clinical effect would be rather than the fact she doesn't have a gene change. There is a phenomenon, and we talked about it a bit yesterday, but I haven't gone into too much, which is a thing called tuberous sclerosis mosaicism. That's not the same as the issue about having a child. There are some people who can have a lot of the clinical signs of tuberous sclerosis, and they have the gene change in most of the cells in their body, but they just don't have it in their blood. So you have to start looking at other tissues, or else you may start looking in much more deeper sequencing, looking at thousands of copies of genes to try and identify it. That may be something that we could look at. It's actually only at a research stage at the moment. As of last month, I think it's just being introduced as testing in the NHS in England for that kind of tuberous sclerosis. So potentially there are things to gain. I don't know how long ago your daughter was tested.
So 5 of those and normal.
Okay. So it's very recent that you're talking about. Yeah, okay, fair enough. Well, I mean, certainly I can catch you afterwards and just take through that if that's okay.
Okay.
So thanks very much for that. So I myself have TSC 2 mosaic form. I suppose my partner and I are at this kind of early stages of planning a family.
Mm-hmm.
And just something that came up at the end, just the gonadal version. I suppose the difficulty I've had with this 50-50 thing with regards to my own presentation of mosaic is it's I know my own number, it's like 17% on a blood test. Yeah. But ultimately it's the gonadal that's most relevant.
Yeah.
In that instance, there's obviously testing available for there was gonadal testing of some form available to realise that that's where the issue was. In that case, you talked about.
One wouldn't normally. That's more related to people where you can find nothing in your blood test. You're obviously a situation you already know that you have mosaicism. It's just you don't have as much of a level of the gene alteration in your blood as other people with tuberous sclerosis might have. If the way I'm interpreting.
Yeah. So I suppose the dilemma that we're looking at is that. How do I explain this? And do please stop me because I may have misinterpreted this. So 17% of my cells are affected. 17, yeah, on a blood test.
Yeah.
But if you were to test different tissue, that rate might be different.
Yeah, not only that, if you had a test in a couple of years' time, it might be 19% or 15%. So it may go up a bit from over time.
But with regard to having a child, what's really important is my sperm.
Yeah.
And ideally, what you want to be able to test is a sperm. Now, I know you can't test the sperm, but this gonadal testing, can that be tested?
No, not effectively. The straight answer is no. Okay. The difficulty is there that there's somewhere between up to described as an up to 50% chance of it being passed on. The problem, if you do a genetic test on any one sperm, you have to kill the sperm to do the genetic test, so it's no good. So that doesn't actually help. And doing tests on sperm doesn't really help either, because it does vary. Those levels will vary in time depending on if you do it, and you will find it there in somebody who has a significant level of blood mosaics as well. So you know it's there, but you can't select the sperm for it.
Okay, thank you.
Dr. Green, you tested my son about 14 years ago, and you tested me and my husband. It seemed like it was a random genetic event. We were clear. But I'm just wondering if things have moved on at all. I have 5 other children, and I have one daughter who has enamel missing from some of her teeth. And I just saw that as a symptom.
Okay, so the important thing about mosaicism is that if it's passed on, the child will get the full version. So even if there's a level of mosaicism in the parent in the gonad, what they pass on to the child will be a full-blown version of tuberous sclerosis. So for your other kids, if they were to get the condition, they would have a full version of it, mosaic. The enamel hyperplasia is one, but not very specific minor criteria for tuberous sclerosis. Is certainly not a diagnostic finding.
That's reassuring.
Okay, thank you very much indeed. We're just going to move on. We're just time is moving on here. It's a pleasure now to welcome Dr. Agnies Van Eeghen. Dr. Van Eeghen is from Amsterdam, and she is a physician with responsibility for intellectual disability, and is almost a pioneer in her field. She works in a large tertiary centre in Amsterdam and has extensive experience in the management of behavioural problems in tuberous, which is a particular interest in tuberous sclerosis. Agnies, thank you very much indeed. You're very welcome.
Thank you. Thank you. And please move around a little bit. It's a long, long morning, so I feel bad for keeping you. But so if you want to move around a little bit or chat or have a drink as well, don't be shy. So I'm an intellectual disability physician. It's a novel specialty in the Netherlands. It doesn't exist anywhere else in the world. I think in the UK there are intellectual disability psychiatrists. It's a bit similar, but we're also trained on the genetic and physical problems that people run into. I see people with intellectual disability, but also genetic disorders with normal intelligence, but also intellectual disability without genetic cause. So I always have to do a little bit of PR for it. And my mission, and also I'm sure later your mission, is to get together the ID world, intellectual disability world, and the genetic world. You're all here because you identify with tuberous sclerosis. But once children grow up, sometimes they get into intellectual disability care, and people don't take the genetic disorder into account. Well, it's so important for health manifestations, mental health manifestations, but also family functioning. So that's important to do. That's why we have a clinic in a very large ID care organization where we do national consultation on complex genetic disorders, but also there we pick up questions which are relevant for individuals to pick up into the academics and to do research. So we do research on CBD oil, not for seizures, but for behavior. We look at outcome measures. We will talk a little bit about that, but also aging. Because all of you are here and all of you have the question, how will my child grow up? And especially when you're not there anymore. And there's very little known on this thus far. So we're also focusing on that. Also in Europe, there are now the European reference networks, specifically for rare disorders, where we try to improve care in Europe, but also develop guidelines for specific genetic disorders, but also for, it's called comorbidity, so shared problems that is shared across all individuals with intellectual disability. So people can look those up and bring them to your doctors. So that's a little bit on the meta aspect, but we're here today for people like Jaap, a patient of mine. We're talking here about a 19-year-old boy. That means he's transitioning from pediatric age to adult age, from pediatric care to adult care, but also other life domains, of course, are changing for him. He grew up as a very, he had refractory epilepsy, intellectual disability, moderate intellectual disability, autism, tics, but was quite flexible, even though he had autism. A very cheerful boy. People really loved him wherever he went, as you can see also in this picture. But when I met him, he was really not in a good place. He was sad, anxious, crying all the time, did not go to school anymore, was worried about the future, was not sleeping. His epilepsy got worse. His mother was just looking forward to working more, but now he was at home, so she had to stay at home again. And now he's already at home for a year. This is a very complex problem. How do we, in the consultation room, you have to think about physical things, mental health things, but also this transitional age. And we know about the physical manifestation of TSC over life. So we know that the renal problems become worse when you grow up, but the risk of SEGA, the tumor growth in the brain, goes down. And we know this for the most organ system, what we have to look out for. But for the mental health, like the tics and the anxiety, we don't know a lot about it over life and a lot about its manifestations. And we don't even know how to talk about it with each other because it's so complex. That's why this term TAND was coined. It's called TSC Associated Neuropsychiatric Disorders. It really concerns anything in the brain. Seizures are officially not included. Of course, it's also part of the brain, very important for TAND, but we are really talking about anything except the seizures here. Why is it so important to call this TAND? Every genetic disorder or anyone with intellectual disability has behaviors or psychiatric disorders, or at least a higher risk of it. But the people tended to focus much more on the physical symptoms, and just coining something as TAND has really improved people collaborating, getting together, talking about it in the consultation room. And since the term TAND is coined, also TAND research has gone up immensely if you look at the publications. And I think most research now in TSC is actually done on TAND, which is pretty great. As you can see, it's an umbrella term. It's really anything. And TSC, of all genetic disorders I know, anything really can happen. I think the only thing I don't see a lot is schizophrenia type of symptoms, which you see in some other genetic disorders. But as these tumors can range up from 0 up to 80 in any place of the brain, you can imagine that anything can happen with learning abilities, with psychological issues, with processing information. So that's why we call it very variable. It can be variable. There's no one person with TSC that's alike in TAND. So there are these different levels, as you can see. If we start to the top left, it's the psychiatric level. This double-edged sword to the psychiatric diagnoses. You get a child who already has TS. You know it's the child probably has epilepsy as well. Why do we need all these psychiatric diagnoses? Probably children of you have had a diagnosis of autism spectrum disorder or ADHD, maybe some stress-related disorder or trauma, anxiety. And parents ask me, why does my child need all of these labels? And why does this adult need all these labels? We know it's part of TSC. And I do think it's important to know that it is part of TSC. It's not something different. But if you don't acknowledge it, we see people as one, and it really helps us to look at treatment targets and improve care and to really understand the person better. So we do think it's important to know someone has an autism spectrum disorder, because it does change how you take care of this person in the house, at school, or in his future situations. It's very important to know if someone has an anxiety disorder. People tended not to diagnose these a lot because sometimes the autism or ADHD was so overshadowing anxiety. But I think now we're getting more and more aware of anxiety. So even in people with autism or ADHD, if the world is difficult to understand, people get anxious. And then your head gets full, as all of my patients say. That's like the one symptom that is shared. You get a full head. You do not process information anymore, and you get anxious. So I think it's very important to look at that as well. So that's the psychiatric disorders. Then we talk about behavior a lot. And behavior is okay to talk about because it's a term we all understand. But it's very important to know that behavior is something that we see. So we observe behavior. Nobody says of themselves, I have this or that behavior, right? I would say I'm anxious, but you would say I'm very inflexible, I'm aggressive, I'm irritable, right? So it's really important if you talk about behavior, what are you really talking about? What is this person experiencing? So yes, you will say my child shows this or that behavior, but it's up to the care provider to interpret that in other terms. And then you look at the other umbrellas. You look at what is the influence of intellectual disability, of not processing information on this behavior. You look at the neuropsychological level. What is the influence of the brain functioning on this behavior? How is this attention? How is flexibility? Can someone organize and plan behavior? And does that affect the behavior? How's the psychosocial level? What is someone experiencing? Is someone in the right classroom? Is someone being bullied or teased? Is someone's self-esteem maybe going down because all his peers are improving, but someone is sensing he's not keeping up and experiencing problems? And how is that affecting behavior? So yes, we can talk about behavior, but we have to keep in mind all the other aspects of the umbrella and how they affect that behavior. And that's what you target your care and your treatment on, not on behavior. You understand it? So you can always ask questions. Another thing that influences behavior is physical problems. That's especially hard in children and adults with intellectual disability who are not able to express their problems as well. So I know as parents, you're always hyper aware of seizures, hyper aware of pain, discomfort, sleeping problems, medication. All of these can also affect behavior. So yes, it's good to talk about behavior, but that should be the beginning of the discussion and not the end. We don't treat behavioral problems, we treat the cause of behavioral problems. And what we know about TAND, of course, it's lifelong. It can be variable. We talked about the seizures. They can be stable and vary a little bit. TAND can also be stable. In terms of the development of your brain, the intellectual disability, the autism spectrum disorders, the attention deficits, these are built into the brain. These are there forever. Of course, it can bother you more if your environment is not adjusted to your level of functioning and to your intellectual disability, but your brain is stable. What is not stable is the anxiety we're talking about, depressive symptoms. Those can really vary over life. The good news is those are very treatable. So anxiety is very treatable. Depressive symptoms can be very treatable. So these are fluctuating, but also are targets for treatment. And it's with medication, but usually that's not even necessary. And now we have a TANDem group, because together we're tandeming towards better care and treatments. And we know it's the biggest burden for you all here and your biggest worry. And so it is for us as well, even though it's very complex. So we got together with a big group. Petrus de Vries and Anna Janssen are the initiator of this club. And well, some people here are involved as well. And we're very closely connected from all over the world, all types of disciplines and stakeholders are involved, even ICT specialists, to get everybody connected. And what we do is we want to build an app for people like you that you can access on your phone whenever you have a question about TAND, specifically TAND. So if a child has a temper tantrum, if a child is anxious, if you as a parent are frustrated, that you can access this app and you get tools and information to understand it, to help yourself, but also to get care and the care that you need. So you can take this information to your healthcare provider. And for you, you are here and you're pretty empowered because you found your way here. But you can imagine for the rest of the world, that's not the case. And parents are usually the bearer of the information. The parent is the expert. So the parent brings the information to the healthcare provider to empower the healthcare provider because they do want to help. They just don't know how. So together they can make a plan using the app. So that's what we're building, and it's actually launching quite soon. So I hope through the TSC Alliance here and through Mary and other people, you get to know it. And fortunately, you're English speaking, so you get the first scoop. Then we're also making guidelines for TAND. And it's actually quite revolutionary to have guidelines specifically for mental health problems and psychosocial problems. And it's revolutionary because it's really hard to build a guideline if there's little evidence. And unfortunately, there's very little scientific evidence. But with all the experts together, we got together and we thought, even though there's little evidence, together we can formulate some expert recommendations on top of the science for you at least to be able to go to the healthcare practitioner. And sometimes it's very simple, like exclude physical problems when there's a change in behavior. If you don't know what it is, just use the regular guidelines. If someone is depressed, please just use the regular guidelines for depression, also for people with TSC. And it sounds so simple, but people, when someone is so complex, are just very hesitant to really do the things they usually do. So just little pointers like that can really, hopefully, help a lot. And then, of course, we want to network and do things like this. So that's why I'm here today. So there's more awareness of TAND, and that you guys also talk about TAND together and your healthcare providers. So we are making papers. The TAND recommendations are now in press. So in a month or so, it should be accessible. It will. We also have a TAND website, a TAND consortium website, with videos, very short videos with information on all these TAND aspects and our recommendations. And they're all 3-minute videos, so they're very accessible, hopefully, for all of you as well. So what are the recommendations? It's really what I just talked about. With any change in behavior, you take a broad look at intellectual functioning, at attention, at flexibility, at the psychosocial circumstances, and then really take the context account as well. If you do that, you can make a plan. But that's not a plan for life. So with any new change in behavior, you have to do it again. So don't be afraid to go back to your healthcare provider if you're worried, because it can be something else, because there's so many factors that come into account. So there are neuropsychological examinations, which you can do about every 4 or 5 years, or before every transition to a new phase in life, to new school or to adulthood, which really give a nice overview of brain functioning. And that's you can do. But you can also screen with the TAND checklist for complaints to just know how you are doing. And once you have that, you really understand someone much better. And for Jaap, that means that once we know what we're dealing with, we can help him. And of course, he was worried about his future. He had just heard he was going to move to a new home within a year. They took him to the place to see where they were building it. They would never have thought he would really be so anxious about this change. Even though he had autism, he had been quite flexible throughout life. So it's very unpredictable. So we had to stabilize him, stabilize his family, and find something to do. And of course, help his family, educate his caregivers. And it took a year really to getting him up and running again. And of course, there are more medical things to do, like citalopram is a drug against anxiety, but that's not really the biggest effect we were looking for. And you hear maybe also about the CBD. We were talking about CBD for seizures, but there are indications that there's also effects on behavior. And because it's a drug that has relatively little side effects, if you monitor it well, it will be very interesting to see. Most anti-seizure medications do have some effect or another on behavior, but it can be very unpredictable. And we want to find out what the effect is on CBD, especially because parents like you are very enthusiastic about its use. So what's going on now? That studies are starting that everybody who's starting on CBD for seizures, we will monitor in 20 to 40 countries in the world, but not all patients, of course. We will monitor for the behavior to find out which psychological issues improve and which don't. So maybe later we know more specifically what to use this for. It's very expensive if you pay it out of pocket. It can be like 500 to 1,000 euros per month. So we have to be really sure what we are treating people with. So because the insurers won't like this drug. And I think in every country now, the EMA, the European Medical Agency, has approved it. I heard, Colin, that you're already prescribing it. So every country is different now. So we are trying to find out the effects on behavior. So we just discussed, this is another girl. This is Jacqueline, or a young woman. When I met her, she had actually experienced seizures very early in life, very well controlled. And she went through education without a problem. She was a shy girl, very pleasant girl, never any trouble to her parents. Finished high school, like a good level of high school, even went to do law studies. She stayed at home doing her law studies. She had a lot of help during her law studies, but she was very intent on finishing this. And after her law studies, she thought it's about time to move out of the house and really start taking care of herself. That didn't work out as she planned. She got an apartment. She was looking for a job. And she found some jobs as a paralegal, but it was too difficult for her to manage the relationships with her colleagues, to manage her work, to plan her work. And she was very disappointed in her own abilities, and of course got very negative experiences. It was difficult for her to hold friendships. When you talk to her, she was very pleasant, but she would not initiate her own conversation or initiate social relationships. She did not have any romantic relationships, and she was very anxious and not sleeping well. And of course, her parents were the same. They were very anxious and not sleeping well. This is also for normally intelligent people with TSC. They can have problems also. And especially we call it executive functioning. So really planning and organizing, integrating everything in life, this very complex life, and making a plan and overseeing situations can be very difficult. So it takes a lot of energy, takes a lot of time. People need much more time to process. So we really had to help her out. And she got more support at home every week to go through her agenda and work things out, to get more social support. And she also had seizures at night that we found out and we treated. So she's doing well now. But for me, the transitional age phase goes up to 30 until all life domains are achieved. And that's much slower than just young people from the general population. And we have shown that this is a difficult graph, but it says children over life can decline a little bit on functioning. And we don't know if it's really a decline or growing into deficits. We call this growing into deficit. Means when a child grows up, the difference between the child and its peers becomes bigger, but there's still improvements also in the child with TSC. But the difference, of course, is still more and more obvious. So it seems that someone is doing worse, but that's not true. Someone is still improving and learning and developing, but the difference between peers is much larger. So it's always important around the age of 16, 17, before they go into adulthood, to do this testing, see where they are in functioning. So we don't ask too much, because the world is very, very complex at this in this age phase. And we did some interviews with young people with TSC, young adults, and they did say they had a lot of questions, of course, on their tumor growth problems, on their seizures, on their learning problems. but also being understood and thinking about themselves as an adult and who am I? What are my strong points? What are my weak points? What is my personality? What is TSC? All these very questions related to your life phase. And it was very interesting to hear people say talk, but also interesting to see how difficult it is for them to really understand their own disorder, as it is for us, of course, as well. I think also important to mention that sexuality and romantic relationships is something we don't discuss a lot with individuals with TSC. Of course, as parents, you're really worried about the physical aspects a lot, and the seizures, and also people with seizures can be very anxious because the seizure can come at any minute. So this anxiety is there throughout life, but also having a negative body image and not having positive experiences with your body is very difficult for children and really affects also your how you view yourself as a person. So I think, of course, it's logical as parents to be very worried about manifestations, but it's also very important to have people experience their body in a positive way. And it's, of course, not only sexually, but through sports, through just hugging and holding and intimacy, and not always being anxious about what goes wrong, but really supporting also what goes right. So people really feel okay. I think a lot of females with TSC I see don't express any sexual interest or behavior, and I really don't understand it a lot yet. But I think that's because the focus of us as healthcare providers, but also of the people around them, is just not on sexuality. So they don't get the examples from friends like our children do. And while it can be so nice, right, to have a good sexual life. So I think it's important to keep on discussing it. I know you're worried about people being a victim or a perpetrator. We can also talk about that if you want, but also focus on the positive health, right, which is now especially important as a person. So I think, of course, it's logical as parents to be very worried about manifestations, but it's also very important to have people experience their body in a positive way. And it's, of course, not only sexually, but through sports, through just hugging and holding and intimacy, and not always being anxious about what goes wrong, but really supporting also what goes right. So people really feel okay. I think a lot of females with TSC I see don't express any sexual interest or behavior, and I really don't understand it a lot yet. But I think that's because the focus of us as healthcare providers, but also of the people around them, is just not on sexuality. So they don't get the examples from friends like our children do. And while it can be so nice, right, to have a good sexual life. So I think it's important to keep on discussing it. I know you're worried about people being a victim or a perpetrator. We can also talk about that if you want, but also focus on the positive health, right, which is now especially important. So this is another girl with TSC, a woman. She's growing even older. Her parents come to me because she's becoming a bit slower. She's taking less initiative. She is okay. She's not unhappy, but she is less physically active. She doesn't take part in activities anymore. She used to really help around the house a lot, but now she sits in her chair. And her parents ask me what's going on and what's going to happen with her in the coming 10 years, because her parents are aging as well. And this was someone who had really very severe ID, self-injurious behavior, which happens in about 10% of people with TSC, refractory epilepsy, and also all of the tumor phenotypes. And I think this is like one of the more severe types of TSC, which I think will maybe become less over time now that epilepsy and the tumor growth is treated much, much better. But these are the questions I get a lot. So what about quality of life in adults? So what is important for adults themselves? We don't really know yet. We don't really know how they grow up, where they live, who takes care of them. on all life domains, how the impact of TSC is on their lives. So that's why we're developing a measure, just a questionnaire really, to ask about the burden of TSC. And we just did that for the first time. And now we're finding out what really affects their quality of life and their burden as well. And that's, of course, on the physical domain, again, the TAND domain, but also on their activities. And that helps for in clinic. So I hope in the future you will get this questionnaire before you have a clinic visit. You fill in the questionnaire and then your healthcare provider can see, oh, the burden is now more on the mental health or more, oh, he's not going to school anymore. And then you can focus your discussion on that. So we know all of these impacts. And we know there are predictors of lower quality of life. And I must say, for people with intellectual disability, this is filled out by parents or caregivers. And we know that the reports by parents or caregivers are usually worse scores than if people score themselves. So that's good to take into account. So the impact on the caregiver is usually worse than the impact that's experienced by the individual themselves. But if you look at quality of life, we see that having intellectual disability or the difficult to treat epilepsy, of course, has some influence on quality of life. We also know the TSC2 mutations have, as a group, more severe manifestations. Yes, that will cause an effect on quality of life. And then if you look at all psychiatric diagnoses, the autism and the ADHD diagnosis, of course, have a large effect of life. I think the ADHD is really the externalizing behavior, the hyperkinesia, maybe the impulsivity, and maybe a verbal aggression, physical aggression. And that's really has impacts, of course, and it's very important to target that very soon if you run into that. Aging, we don't know a lot yet, but we can think about seizures and medication and its effect on aging. So we're looking at that to see, do people age, or does the brain age quicker or not? And if it does, is it the seizures or something else that causes this aging? So that's what we're looking at. Well, so I'm hoping really to have a discussion together because I'm sure you have lots of questions, but I think we try to prevent, so any behavior you see, try to prevent it becoming worse, which is easy to say because I know there are long waiting lists and very lack of appropriate healthcare professionals. So I know that, but hopefully with the TAND guidelines, it will help you a little bit further. The periodic neuropsychological examinations looking at brain function really helps understanding, and the transitional program from pediatric to adult care is also very important. So I hope this was just an overview. I know you must be tired just before lunch. I see people yawning, which I really understand. So feel free to come up at me at lunch if you don't have energy for questions now, but feel free to also ask questions at this moment. Thank you.
Thank you, Agnies. That was a wonderful talk and very down to earth and understandable. We're going to make a wee slight change to the programme. We feel that we've been working you too hard. You've had to listen to quite a lot. We're going to have some questions now and discussion with Agnies, and then we're going to break from lunch from 12 to 1. And then Colin and Mary is going to talk after lunch, and then Chris is going to talk, and then Chris and I'll talk on living with TSC, and Chris and I'll have a joint question and answer session at the end, and then the round table. So, and to get you a chance just to talk as well. And we encourage you to all just to talk to the various speakers during lunchtime and coffee break. But anybody, any questions for Agnies?
Yeah. At what age do the neuropsychological disorders typically present?
Once someone is born with TSC with the brain manifestations, you can expect some neuropsychological effects of that because your development of your brain is different than other people. The development of learning, of speech is already neuropsychological. It's already a manifestation of brain functioning. So yes, with any brain abnormalities, there are some neuropsychological manifestations that you can expect. Of course, if someone has a high IQ, you have all these shortcuts to go about it to try to compensate for it. So maybe you don't see it as much, but that's what I talked about with the executive function problems. Even though someone looks normal, as normal, sometimes it does take a little bit more time for people to process and learn and to work together and to go about social relationships, even though someone might be normally intelligent. But it's important from a very early age to follow this, of course, to see if someone is declining. Is it seizures maybe at night or something like that? But it is quite stable, the functioning. And we recommend before transitioning to every new schools or from pediatric to adulthood to have this really broad examination, because it really helps you understand how someone is functioning. Someone can be verbally very strong, but really not understand so much. Someone can do maybe everything, even with autism. If you teach people, they can do all these tasks, but maybe if they switch to a different context, this is totally illogical for them and they will lose skills. And you will think, oh no, they're losing skills. No, it's not. They're not losing skills. They're just in a different context and they have to relearn things in a different context. So having this broad examination and also experts on the field to really help interpret this really helps a lot, I think. Yeah.
Thank you.
Hi, so I'm just asking about the app that's starting the TANDem project. Is any aspect of that open source? Because I myself have a background in cybersecurity and particularly for thinking that we come to audit or things like that, or you have the computer side on that background. So unfortunately, I'm kind of contributing. And I have another friend as well who's projects work on courses.
Nice.
So projects.
I'm sure if you go to Colin or someone else, there are always projects to do. The papers we publish are all open access, it's called. I think the TANDem Consortium website is really the place to go. And then the app, of course. And I can imagine implementation of the app maybe in Ireland is different than from other countries. I know Mary is doing some research that needs a lot of ICT work. But I think if you be careful what you wish for, but I'm sure they can make use of you and your friends. So thanks for offering that. Yeah.
Do you have any advice for a 3-year-old, just someone just turned 3 with delayed speech, or like recommendations on like what we could do next to help? He's very like clued into everything and communicative. It's just delayed speech.
Right. I think so. That's important. The neuropsychology, exactly like you say, is it to be expected, looking at it overall functioning, is speech just one of the manifestation of a developmental delay, which is very proportionate also to cognitive function or other functioning. If speech is really significantly different from overall intellectual functioning, that can be true because as you maybe know, the tumors can be in different places. So it can be just in a place, or the epilepsy can be just in a spot, which is very important to speech. I think it's very important that people know, even if we understand it and it's developmental, it doesn't mean it cannot be treated. So some people say, oh, it's TSC, and they stop doing things. No, that's not the message. So absolutely, you should get treatments, and you will get the diagnosis maybe of a language, how do you call it in English, when it's like a specific language and speech disorder. And you will hopefully qualify for the similar type of intervention that is would be given to other children with the same problem. Yeah.
Very interesting. Very interesting. I'll just made a couple of points for me that umbrella. Just interesting the perspective of how there are just some that the umbrella, I think, within city they might have difficulty with It's a psychiatric disorder, there's no publication. Checklist and you have to fit it in somewhere. I think, people themselves, TSC and diagnosis, sometimes see themselves as just being having a production, but it's an interrogating process rather than having said, so that's just what about pointing to the change the period of that. And the other thing then is that it's very difficult to with a disorder that's so complex. Each of the individual components are treated differently, so you might be, you might get some support for your autism, but obviously you might also develop inflammatory difficulties, and you want support for that, but you're balanced back to your diagnosis. You might, so if you have a difficulties, it's you're told no, sorry, we can't do this with the services. We need to be pushed back until your diagnosis is developed. Nobody ever looks at TSC as a whole very early pattern of your individual issue. It's almost like you can't have a complexity of difficulties. So because you're in the disabilities are can't have it in the problem within that brain.
Right.
So I think that's one of the terms in this is look at TSC and all of the whether it's a great diagnostic, a great concept and a graphic that I think is really but it's very difficult in our material. They're not treated in a holistic individual.
Right.
It didn't work in their own setting.
Right. Yeah.
And those of the apparatus that TSC, they might have to go but you got around with that.
Right.
That's something that we need to get through.
Yeah, no, it's I totally hear what you're saying, and I'm not saying in Holland it's that much better, but I think a coordinating expert is very important. It can be a nurse or someone else, but really that's why we like it is biomedical social aspect, and I think also in support plans, but also as doctors, we really have to. These are just labels, and we use the labels, but I think it's very important to when we describe someone, we look at the medical, the mental health, and the social, and really that's how I write my letters. I write my conclusion, but also my recommendations for the individual on each of these domains. And it's really there are so many things to do, right? So it's important together to share and make decisions and prioritize what to focus on. So that's I think also important to write. So what's for you, and also I do it to save time. So what's the top 3 of your worries today at this moment? And then prioritize, so what do we have to do today to help out? And, in 3 weeks, it might be very different things, but it's important to prioritize, to look at quality of life. So what's really impacting quality of life for your child, but also for yourself, of course. Yeah. Wow. Yeah.
I don't think that microphone's not working. That microphone's not working.
And the second one is that there are any without going to a business or without
So I don't think the microphone is working, Carla. Can you translate, or maybe you can talk a little bit louder? Oh, yeah. So I think I can say a little bit about medication. I think you were talking about anxiety medication. So I will give a little mini lecture on medication for TAND. I think we have to be careful not to give too much medication because medication gives side effects. Especially we don't like antipsychotic drugs. Historically, these were given a lot. It's when people were aggressive or very difficult to manage. And these have long-term side effects like overweight, hypertension, but also dulling and less development. But I do think sometimes people are undertreated as well. So I think if there's anxiety, and that can be very impairing anxiety, there are lots of strategies on a behavioral level, but also on a medication level to break through that and try to become more flexible. I think ADHD, we don't like the diagnosis. Of course, it's overdiagnosed in children of the general population. But I think when people are very impulsive or very agitated physically, these medications are very easy to try and also very easy to stop. And I think they're not used enough because it really can prevent the next step to antipsychotic drugs. So I think especially ADHD medication and anxiety medication, there's not much against it just to try. But I do recommend if you start something with which may have side effects, to set goals. We were talking about it yesterday, but it really should impact life in a relevant level, not just a score on a questionnaire, but really think, what do we want to achieve with this medication? Does someone maybe sit on a chair in school a bit longer and finish the task? Does it prevent someone from becoming angry? Does it help someone to get in a bus in the morning? Instead of, sometimes people take hours and hours just getting dressed and then you're all wiped out and then someone stays at home. So really set very practical, concrete, we call it SMART targets when you use medication. So don't just use questionnaires, but really relevant goals. If you don't achieve that goal, stop it and try something else. So that's how I go about it. So, yeah.
Okay, and the first one I was asking that can TS affect like menstruation like in female patients?
Sorry, I don't understand.
I was asking that can TS affect menstruation in female patients?
That's I would love to investigate that. There are no studies on it. I do see more blood loss sometimes. So definitely there are indications that you can have hypermenorrhea, but I do see that sometimes, but it happens in a lot of women. So I'm not sure if it's really TS related. So sometimes more blood loss for sure. And of course, just in case, that if you use things to regulate menstruation, don't use things with estrogens, right? I'm just saying it, but please keep that in mind. No estrogens supplementation. And actually, we work a lot with also the Mirena and Kilena, which sounds very invasive, but it can be quite helpful also if you're looking for contraceptives or other things. Yeah.
Thank you.
Just a quick question, perhaps because you're working not so much maybe on the physical side about that, but perhaps with all of these young people, the premenstrual thing, affecting TAND.
Yeah.
Is that something that can be looked at?
Right. Yes. So we know premenstrual syndrome also occurs, of course, in girls and women with any type of intellectual disability and also with TSC. We know that moods can be very volatile in TSC. I always try to explain it. If someone has seizures, they also have a lot of discharges, electrical discharges in between the seizures. That means that things go on in the body all the time. And if people also have like sensory issues, problems with integration of issues, that really can cause a lot of volatile moods, irrespective of what happens in a context. So you can be a stable family, a stable school, and still the mood can change. But that's really because it comes from the inside, not always from the outside. So that's one. So the moods fluctuate a lot. And you can imagine with someone who can be moody and unpredictable with PMS, of course, you can be more irritable and moody. And so it's important to really monitor it. It's not so easy to treat. Of course, you have to be careful. It's not pain. You can treat pain and prevent pain. So that's something you can practice, right? Just a couple of months to get some pain relief and painkillers. And yes, there is, of course, the Kilena or contraceptives can stabilize it a little bit, but it's really very variable per person. So I'm a little bit hesitant for that. But no, it's good to monitor it and just understand it. Like women have to be understood a lot better. Yeah.
All welcome back. I hope you had a good lunch and a good chat. And we're just into the final session now. So with the revamped program, we're going to have Mary and Professor Doherty and they're going to talk about TSC in Ireland and making the invisible visible. Both of these folk don't need any introduction. Okay, thank you.
Thank you all. Okay, good afternoon, everybody. I was speaking a bit. That's your slide.
Yeah.
I'm not using any slides. You'd be glad to hear. So yesterday I talked a little bit about how I, with the help of some very important people, have put together the nucleus of an expert service for TS in Ireland, and probably the only one in the country, which is now in James's Hospital. I say that, tentatively because, if everybody in the country with TS suddenly descended upon our clinic, we'd be drowning, and to get to where we were from really nothing to where we are now has taken a long time. So I trained in North America with Elizabeth Teal, who's one of the world's experts in TS. And I left there in 2003 for various reasons to do with my own family. Elizabeth had asked me to stay on actually she's a pediatric neurologist, and she needed an adult neurologist to stay and do TS with her to become one of the premier clinics for TS on the East Coast of the United States. She had just received a gift of $10 million by the Hirschkott family. So this kind of philanthropy in the United States is much more prevalent than we get in Ireland. Like, you're much more likely to get a stadium built for your local GAA club than get a gift like that for a healthcare. I actually something that we should talk about and how to change that, because I do think it's amazing that people drop, and like 10 million was a lot in 2003. People drop 150 million, $200 million in the United States now for healthcare related projects, very, very commonly. So I left there, with potentially a career in focusing on TS, and came back to James's Hospital. And I said this yesterday just to give you an idea of the difference in the healthcare system. So Massachusetts General Hospital had 160 neurologists attending the hospital. That was on the staff. I came back to James's, I was the second one. And they're both the same size, those hospitals, 1,000 beds each. So I couldn't focus on TS for the first, 7 or 8 or 10 years of in fact, I wondered where all I thought I might be inundated. Where are all the TS cases? They weren't, I don't know where they were, but I wasn't particularly looking for them either, because I knew I couldn't cope with something, being highly specialized, given that I had to take care of epilepsy as a whole. I was talking about the numbers this morning. So, 45,000 people with epilepsy, and we've grown to be one of the largest in the country now in James's. We probably have, we're probably responsible for about 10,000 cases of epilepsy coming to our service, or at least in the catchment area of our service. And we probably have active patients about 3,000. What I mean by that is we have patients who are stable and seizure free who don't come in to see us. And then there's about 3,000 patients who are coming back and forth because of difficult to control seizures. And buried among those is a group of patients with TS. And it was the arrival of Claire Behan, who came as an epilepsy nurse specialist back in about 2011, who over a couple of years realised that this group of patients had particular needs, not just because the epilepsy is difficult to control, which can be, but also because of all the other things that go with it. And we realised that coordination of care in a specialist centre, making sure the kidney doctor and the scans get done and the bloods get done, and then there's the lung disease in women, and then there's the skin disease. And so that coordinating care became the big challenge. And Claire has sort of perfected that, at least in James's. Claire could be transplanted to Limerick tomorrow and she wouldn't know how to coordinate care, because every institution is different. So that's another problem. And then that gave us the opportunity to start to consolidate around, seeing patients, particularly transitioning from pediatrics to us, and, then coordinating the care. And then that allowed us to do the first audit of care in Ireland, which Claire published last year in the Irish medical literature, which really showed how we were doing against international best standards. And in fact, in some ways we're doing well, in some ways we're doing very badly. So for instance, after the last talk, Agnies says, I don't know if she's still in the audience there, but like we don't really do any assessments for TAND or deliver any interventions for those kind of issues, even though we know we should. We don't have the expertise. We don't have anybody with, a background in psychology or intellectual disability working in the service. So on the other hand, we also have access to lots of things. We can get genetics done. We have great imaging services. We have great radiologists. We have good neurologists. Our renal doctors are very good. We have a brilliant skin expert, Alan Irving, who helps. So, we're doing well in some ways and not in others. But, and that led then to the third important woman in this story, which is Mary Vasseghi, who's going to talk now. And a lot of you know Mary. She's spoken to you, and you've helped do her research. And Mary is doing, I think, a very, very unique thing with her research, which is walking in the shoes of people with TS, and obviously her unique relationship with Fiona. Fiona's in the audience. Where is she there? Very unique relationship, obviously, to TS. It's also true to say that Mary has an amazing pedigree outside of just the TS related stuff. She's also the Irish representative for patient safety in the WHO, which is a really, really important role. And she's had a lot of experience in developing policy and services in Ireland for other conditions. So her son, Fiona's brother Darius, died age 17 of sudden adult death syndrome. And Mary took it upon herself to help design and push the policy decisions needed to make a screening service for young people to try and avoid sudden adult death. So couldn't have a better person. And then to ring me up and say, Colin, I want to do something in TS. Like, that was one of the most important phone calls of my life, to get a call from somebody like Mary to do. And she'll tell you herself, she didn't start off as a researcher, but she's learned an awful lot about research. And we conceived this research together with Claire and myself and Mary, but it's all her work. And she's going to get a PhD out of it. And she's going to talk a little bit about the project now. And if you're in the audience and you haven't had interactions with Mary, you need to, because this is the last thing I'll say. And I had a very good conversation over lunch about this. You see, what you need to understand is that, let's say we are, for argument's sake, we agreed that, we need more investment in services for people with TS. That's a kind of a given. That's not a hard statement to make. It might be a little bit of an argument of where those services go and what the background of those people are, and would you prefer a psychologist versus another nurse specialist, or but let's say you had your wish list. You could just get every expert you wanted and put them, let's say you were going to put them in James's hospital because we already have the nucleus of staff there. Why hasn't that happened? Why isn't that obvious? Why isn't somebody knocking on my door from the HSE saying, Colin, you have this HSE interest or this TS interest, we want to put a service here. Why is it ridiculous that never happens? That seems amazing to me, that we accept that, the politicians who are supposed to be serving you, right, never come to me to say, Colin, we want to resource your service. It's always me knocking on the door of the politicians. And in a health service like the Irish health system, it's resource constrained. So there's always priorities, like cancer. Cancer gets money, gets investment, right? Children who need heart transplants, that gets investment. Breast cancer gets investment. So epilepsy doesn't get investments. TS certainly doesn't. I mean, like, why is it that, for instance, all of you who live in the community, if you probably don't even know who your local representative is. If you do you think they know anything about this condition or your needs in it? I'm really making the case here for not just that you're a group of patients and this is a knowledge exchange and you're learning about the condition and hearing about scientific advances. I'm making the case for activism in you. Because I've done it. I've been knocking on the doors of the politicians. You'd be amazed at how much more powerful your voice is. For you, this is an existential crisis, right? Think of that word, right? You exist every day with this. And if you're in trouble with the condition, it's a crisis. So for you, this is an existential crisis. It's not for me. They know it's not for me. This is my career and I'm a professional and I'm committed to trying to help people with this. But, you know, it's a very different message that you're bringing to a policymaker or a local politician than the one I'm bringing, which is, oh, that's just another consultant who wants resources. So they all want that, you know, that's the view they have. Whereas you're a group of people with an existential crisis. So let me just take one practical example. If you are in this audience and you're not a member of this organization, that's inconceivable to me. It's inconceivable to me that you're not currently an active member of this organization, because this organization needs to be a group of activists who, you know, will go and advocate for yourself or your relative or your children or your mother or brother or sister, whoever it is, to get the resources that are required. Now, in terms of what those resources are, that's a good point. Where probably where we have fallen down is, you know, we need to work together to design the sort of business case, if you like. And I was talking at lunch about that, about doing a kind of design thinking workshop about designing it. And I think when Mary has her, maybe in the second half of this year, when she has her research results put together, and you're going to see how she went about that. I think that's time for us to get together and design this pathway and design the costings and design the staff that we need, and then just not take no for an answer, you know. And what that means is, you know, the squeaky wheel gets the oil. You have to be knocking on doors and people have to know what TSE is. You know, it's not acceptable for your local politicians not to know what it is. You're going to tell them what it is. And you're going to tell them the services you need. And I'll be there. I'll turn up any day you want me to, you know, but, you know, I spent my life doing advocacy for services, and we built up a great service in James's for epilepsy. We've got 5 epilepsy nurse specialists, and we've got 4 doctors now who are experts in epilepsy care, and we've got a specialist dietitian. So we've, you know, all of that stuff wouldn't have been there without advocacy. But with a rare condition, it's really hard, because in a resource constrained environment like the Irish health system, there's always something ahead of it. There's always something that will get the politicians' gaze. So you need to be the squeaky wheel that gets the oil. You need to be there. Well, this TS organization, it's a pain in my ass. I need to give them what they need just to get them off my case. You know what I mean? That has to be we want them to be sick of us, you know. And that has to be you. Because I'm telling you, you have to understand, this is not about the willingness on my part to do it. I'm telling you that I've been there. I've been in the policy debate. You know, your voice is much stronger politically than mine. You know, head of the medical school, Trinity College. Oh yeah, he must have loads of power. It's just, it's hard for me to get across to you how important and how much more powerful your voice in political terms is than mine. I'm just another wealthy consultant who just wants more services. That's all they want. They all want more of everything, you know. So anyway, I'm going to stop now, and I'm going to ask Mary to talk a little bit about her experience, or about the research she's done. But the last thing I will say is that one of the things that we want to avoid doing, and this is why Mary's work is so important, and waiting for Mary to analyse it and bring it to its full fruition, is one of the mistakes lots of people make in this situation is jumping to the solution. In other words, you know, oh, we went to that conference, we know exactly what we need now. You know, we need to resource a service in James's, and we need experts. And, you know, for instance, I don't know the solution to this. So that's why I mean, we can't jump to the solution. There's no way we're going to have experts in every corner of the country. That's just not going to be possible. Even if we had the money to do it, we wouldn't have the trainees. We wouldn't have enough people with an interest in it. So the question is, how do you design a service that has, you know, that allows people who are not experts, who go, oh yeah, I know there's a national service for TS, and I know how to send you there. And not just that your local neurology service knows, but your GP. How do we get into your GP's head, right? That you have TS, and that you need, you know, and that he knows, or he or she knows, how to get you to the specialist service. That's not an easy answer. We heard yesterday that there's 24 rare diseases now in the rare disease network. So just, have a think about what your poor GP is trying to do. He's trying to deal with all the normal stuff, heart disease and lung disease and asthma and diabetes and aging and dementia, all those common things. And then there's 24 rare things, Doctor, I've got von Hippel-Lindau syndrome. Why can't you get me the service I need? And he goes, how do you spell that? So I don't know what the answer to that is. I'm actually not, and I think there again, that's where we probably need to come together and be creatively think about the solutions rather than jumping to them. So I'm going to stop there and ask Mary to come up and tell you about her research.
Okay, so hello. And first of all, I want to thank Professor Doherty. He is an absolutely wonderful man, and he is so downplaying the work he has done. It's very simple. Like, he set up an electronic record, the only one that's running in the country for epilepsy. Like, we're all waiting for electronic records. He has done huge work in all domains. So I really thank him. And he has done a lot of work for you, even though you don't know it yet. So anyway, the idea of today, and I know some of you, is just to show a little bit about the study that I've done. I showed this to the clinicians yesterday, and as you know, some of you are here when I've interviewed. There are others who are not here who I interviewed, and what I got them to do was, rather than me say what I found in the interviews, I got them to speak your voice. But anyway, that's for further down. So what I'm going to do here, and why isn't that working? Paul, I'm kicking this button. Andrew will know me with computers. This one? Yeah, I did. Oh, I just didn't press it hard enough. Okay, sorry. So I know that you've had from the clinicians, but this was my simplified version about TS and about this, what I call it now, an mTOR disease, because that's what it is. You've heard about this mTOR thing. So we know that it's a genetic, we know that there are the benign tumors growing around, we know that most cases are out of the blue, and that everybody is affected differently, and that you can have practically no symptoms or severe ones. So this was a simple way that I had of understanding the pathway, which they've shown you already, and I liked Andrew's brakes on the car. So you have all these things going through your body, and eventually it more or less affects how your cells grow down here. Okay, so in a normal person who doesn't have TS, it just happens. But then when somebody does have TS, this is what happens. So those cells grow, they grow too big, they grow too many, and therefore you have all of these growths throughout your body. But then now you have this new discovery, which only happened within the last couple of decades, that you have the medication that everybody's talking about, sirolimus or everolimus, and people have it spelt in different ways. And that, because you see in the first pathway here, this mTOR will control how the cells grow. And over here, because mTOR, it's having a free rein in your body, nothing is controlling it. So because the TSC1 and 2 genes would normally control that, they're not working. So it's like having a tap that's on all of the time. So that's why these cells grow. So with the mTOR inhibitor, that helps control that. Now, there are UK guidelines as to how to deal with somebody with TSC. There are international guidelines about it. And what we need in this country is that we have the guidelines are implemented, that we have the expertise, and we do have it, you'll see in a moment, and that we have coordinated care. If we have those three things, that's what we need. So then this is just a quick overview of what TSC manifestations look like. Because as you know, it can be diagnosed during pregnancy. The heart tumors can be diagnosed during pregnancy. Why isn't this working? Then the ones in the brain that can sometimes call the tumors called SIGA will come in childhood. And 85% of people with TS will have epilepsy. And refractory, this fancy word, means that it's hard to control. And then we have TAND, that has just been spoken about. And the skin manifestations keep going on through life. So as you can see, it changes. It's not that you're born with something and that's the way it stays. It changes throughout the lifetime. But you know enough about that. So Ireland with TSC, where are we? I think ye know this, whereas perhaps the clinicians yesterday didn't. We have limited Irish research. We don't have or didn't have, we now have the beginning of the TSC clinic. We didn't know if the international consensus guidelines were being implemented. So we don't know how many people have TSC, where they are. It may not be 700, it could be more around the 5, but even then, we don't know who they are, how they're affected, what treatment they receive, or who provides the treatment. And the other thing we don't know is, what do the healthcare professional needs? So this whole project then was to look at some of that. So Professor Doherty, you've just met. We decided that the best thing to do was to look at the gaps and the barriers and the facilitators was going to make this work and make sure that people with TS have access to the proper care. So as he has said, I don't have experience in research. So he has, and then onto that, I have 4 wonderful people to guide me because they're all very well equipped to do so. Dr. Galvin is a professor in the academic unit of neurology in TCD. Dr. Ailish Burke is a wonderful lady who is involved in a professor in intellectual disability and aging. Professor Darko, who's a professor of public health, and Claire Behan, who's here, who's the advanced nurse practitioner with a special interest in TSC, and who really should be doing this project. But she's actually doing her PhD on biomarkers in epilepsy. So it all ties in together. So these wonderful people are able to help me with this new field of research. So the aim then is to build this body of data so that we can do something with it and get the service running properly. So what did I do? First, Claire, as you heard, did the first audit. Then I am doing and have done inpatient interviews to get the lived experience of TSC. Burden of illness and quality of life. There was a study done a number of years ago across Europe, and some of you have completed this survey. And if you haven't, please come to me because it's an anonymous survey. I will never know who answered what. There are simple questions that were designed by other patient groups throughout the world, plus quality of life. And then there is an epilepsy questionnaire if the person has epilepsy to complete. And really, it doesn't take more than 10 minutes to do so. And the results are anonymous. And then I'm also speaking to the healthcare professionals to find out what it is that they need. And then for a number of patients, it will be to map their journey because everybody's is so individual. So these are the guidelines which I mentioned. I'll just go through them quickly. And if you don't have them, they're accessible, and just let us know and we'll tell you where to get them. Because it's good for you to know the guidelines so that when you meet your GP or anybody else, that you can say, hey, this is what should be happening. And as I said, implement the guidelines, access expertise and coordinated care. This then you will recognize as being part of your life because you have to see all these people that we call ologists. So you've got the neurologists, the nephrologists. These are all the people that you have as part of your life. And other people have even more than that. So it's an awful lot to be coordinating. And for many people, it's the parents end up doing this coordination of care. So that's what we have to change because there are different guidelines as to who you should see and when. So, sorry, I thought I had a different slide here first, but I'll tell you about it. So first of all, Professor Doherty mentioned that Claire had done an audit within his service and another service in Dublin. And that meant going and looking at patients' files and seeing where the guidelines that are in that previous document being adhered to. Where the tests that need to be done, being done at the right time, etc. So that I built on by going and visiting the other neurological services around the country. So we looked at 22 adults and 20 pediatric, and the epilepsy nurses in the services, despite the fact that there was COVID and a HSE hack, that you all come in contact with them, that they are so busy that they probably can't have a coffee or a lunch break. They took and did this audit, which meant going through people's files. I went and got all the things that needed to be done from Trinity. We had online meetings. The audits were approved. That had to be approved within each hospital. The patients were selected, visited, and then we uploaded all of the results, and then these results were analysed. So what did we find? Oh, sorry, this was Claire's side. So number one, Claire had already discovered 41 patients in the 2 hospitals that I mentioned. So between all of the hospitals, we only discovered 136 patients attending neurological services throughout the country with TS. Now, if you remember, we should have a couple of hundred people with TS and 85 to 90% of them with epilepsy. So they should be somewhere on somebody's books, but they're not. So we're missing people. And when it comes to how many adults and pediatric services that we looked at, the nurses, not we, the nurses looked at in each service, there were altogether, we had 95 between Claire's and this study. So when you look at the guidelines, and Professor Doherty has just said it, in Ireland, we are lucky, we actually do have the experts. We have the nephrologists and the neurologists and the cardiologists and all of those ologists, they're here. And as he said, all we have to do is get them just working together around the patient. But the care is fragmented, less so in the pediatric services because you go to maybe Crumlin and you've got most of the people you need to see there. Maybe you go to Temple Street and you can get a lot done there. But if you're in the adult services, maybe you have to go to one hospital and then the next and then the next, and it's a bit fragmented. So the results aren't quite as good in the adult hospitals. And then when we look at the baseline tests that are supposed to be done, you'll find again in the pediatric services, a lot of them are actually happening. So the brain MRIs are happening. And TAND, there isn't anybody who's had that special questionnaire filled out. However, I know that many will have had other psychological tests done. But the specific TAND one that is now in development on the app was not completed either in adult or child services, and most people didn't even know it existed. So when you get this app, or even before then, when you can get the paper format, they may not even need it now, it's good for you to know about it. And certainly afterwards you can educate, and it will be for you, who will be more educated perhaps than the people you're dealing with, to teach them about it. Then I not completed either in adult or child services, and most people didn't even know it existed. So when you get this app, or even before then, when you can get the paper format, they may not even need it now, it's good for you to know about it. And certainly afterwards you can educate, and it will be for you, who will be more educated perhaps than the people you're dealing with, to teach them about it. A number of you. So I met 7 adults and 3 of these people had TS children. And then we had a number of you females with children who have TS themselves plus children, parents, some of you here as well, 14 people who didn't have TS at all, who have TS children. Then there were TS positive children who had special needs. And then 4 of the people, not just children, adults and children, are actually in wheelchairs. So that gives some idea as to what is happening, what patient experiences are, and what patients' needs are. So an overview of what I have found, and I'll read out some examples in a moment. So depending on how people are affected, really, it's that variability that's what I found. That it's just so totally different for people, depending on how they're affected. But the bottom line is that in every house I went into, it's the love that keeps people together. The love you have for the child who's affected, the love that that child has for you, the love that happens in that whole family to support the person who's affected by TSC and those caring for them. And I suppose one of my big concerns when I've done this is the capacity for parents to cope with this disease, the capacity that people have to cope for a member with TSC, especially in a service that is so fragmented. It is just so hard. And I really feel that it is the love that you have for each other is what's keeping things going. And that's within the houses. And that is was in somebody's kitchen. And I just felt it so true that being part of that family meant that you were going to be loved forever. And as I said, when I was going, well, I didn't say it, but when I was going around the hospitals, meeting the nurses and the doctors who took part in the audit to go through your files, we don't have an electronic patient record. So it meant them pulling out your files because there's no registry of who has TS or who hasn't. So they had to spend a lot of time finding you. Does this person have TS? And then did they have their renal test, et cetera, et cetera. It took a lot of time, but they are so interested in your TS. They're so interested and anxious that you get the proper treatment. I remember speaking to one girl and it wasn't planned that she was there that day. It was supposed to be somebody else. And I can still see her face. She's, oh, I'm so happy. I was just thinking of this little boy on my way up this morning and saying, you know, what are we going? This is just terrible for this boy. Should we bring him in for one day? Should I keep him in overnight? What is easier for him? They take ye home and your problems. They take them home at night, think about you in their sleep to see what it is that they can do. And again, we're working without this coordinated service. So it's harder on the healthcare professionals who are trying to deliver the service to you. So there is that network that is starting with Claire. And I've heard so many people come and tell me, and you'll hear it here, is how it makes things so much easier that they have found a place where care is coordinated when they're coming from a place that isn't. And as Professor Doherty said, that is starting here. We really do have all those experts. And now it's just a question of oiling the machine. And then I think that the future is so much brighter. Now, what I heard, some of you will recognize some of what you heard, or what I heard, because I'm just going to say for other people, and the only reason I'm saying these out loud is that it's very difficult with TSC because everybody's affected so differently that some people will have one experience and the other, and they're not going to necessarily say it to others, what their own personal experience is behind their walls. So I'm just going to read out a few things. And this is from somebody who's not here today, and you'll hear why. So, and I think you can tell me shut up because it's too emotional for some of you, for some of these things, but I'll go for a little bit. Yesterday, I got the clinicians to read these out so that they could understand and be your voice because you weren't here. So this particular person who's not here today says, it took us 5 years to get a diagnosis. TSC changed our lives. You're used to living with the developmental delay, but it's the TSC, it's the epilepsy, it's a disaster. That's the killer because you can't leave her. No one wants to look after her because they're afraid. That's the problem. You have no help. And it's a huge burden, like you have no social life. We don't have a social life together, only when she goes to respite. And we have 15 nights where we can go for a meal. And for the rest of the 350 days, one of us can go out while the other isn't going out. And that are clear words from one person, but I have met others in my journey around the country who are living the same thing and who aren't here today because they can't, because they haven't got respite. And then somebody else said, I mean, me and my husband, we didn't sleep for months because she was waking up and going into seizures. And another one, and this one I think you will relate to as well. From the epilepsy point of view, he is the doctor's working on the medicine, but from his behavior and psychological side, he's not getting what he needs. And then somebody else who says, it's pretty horrible. It's really horrible to suddenly find you have a child with a life-threatening illness that you've never heard of, no experience. And then all the testing and the appointments. And then we had to be tested to see if we were genetic. And then somebody else, we had to wait for the MRI. That was an extremely stressful ordeal. It was cancelled. So I said, we're due up on such a date for neurology. I was like, could you please try and rearrange it? Because what's the point of going to the appointment if we have no further information, if the test isn't done? And then maybe you've had this experience. I get these letters and I get them to say that she's had an appointment, but it frustrates me. She's on a waiting list. But then they send out this letter after a few months saying, your daughter is on the waiting list. Please respond to this letter if she still needs the appointment. So like, if you don't respond to this letter, she's going to be removed from the waiting list. So like, I'm saying, why are they sending out these appointments? If she's referred to a cardiologist, she's referred to a cardiologist. What about the parents who don't respond? So as you can see, this isn't medical, this isn't the professor or the medical thing. It's a pure administrative thing that should be and can be ironed out. And then I think just overall around coping, somebody said, I find it hard to name what's what. Is it because of the epilepsy? Is it because of TSC? Is it because of, I find that hard. It's hard to know. I can't name it. You wonder, is it because of the drugs? Could he perhaps be having little seizures? Or is it because he just has a language disorder? So for a parent, it's very hard to know where one starts and the other finishes. And a lot of people said, we just get on with the day-to-day. And then somebody else said, it'd be much better if there was a place where all the doctors could see you. Even if it took 1 or 2 days, instead of having one person 1 week, you have to travel and go and see somebody else the week after, and somebody else or something else the week after. It's time consuming. So it could avoid you money, and it would avoid you on having to travel to all these places. And then, I'm just moving, I don't want to read them all out. I had a few marked. And then when I asked people about, not necessarily, as you know, you don't have to have a physical test everywhere. Maybe you can have the test or the X-ray or the MRI done near home. Maybe your specialist is here in Dublin. So it's like, if you need a physical checkup, you could go in. But the thing is, you could do a video call with all of those at the same time. And then everyone would have the same information. And that was something else that was pointed out, that they were discovering that one doctor didn't know the results that the other doctor had received. So again, we're back to coordination. And then we have comments about the service that Professor Doherty and Claire are doing. The care has been brilliant. This person has had good medical care. He's had his MRIs. He's had his scans routinely every year, every so often. I couldn't complain. Everything was very good. So all his treatment is now in James's, which is much better, you know. So that's another comment. And then somebody else said, I look forward to the day where TSC is known about. And like other people and young people with TSC and kids with TSC, when they find out they have it, they're not like, oh my God, what the heck is this? So then we come across the fact that many GPs don't know about it. And then we come to somebody who said it just took a long time to get there. And I told my husband, we don't just accept what we're told. We have to advocate. We have to fight for her until she's able to fight for herself. And I think a lot of you are having to do that. And a lot of that is because I know what the system is like. There are so many people who don't know what the system is like. Now, there were a lot of comments around the needs for the early intervention team, a lot of people who are waiting months and years for care. So I think a lot of you are in that situation, so I'm not going to carry on reading it out. Then we have a number of people who are worried when they have older people who have older children, who are concerned about what is going to happen to them when they're no longer here. So it's the difficulty in finding appropriate places and care for people who are older and perhaps more severely affected by TSC. That's a very big issue for older parents. And then We have the fact that because TSC is such a hard thing for you to deal with, you just don't have the capacity. And I know Professor Doherty wants us to be there giving our voice, and we do have to. But there need to be many of us doing this because everybody's head is so busy with what's happening in their daily lives that it's going to take a lot of us to do a little to get to the weight. It's like all those little drops that will go into the glass of water. That's what makes it up so that it becomes a glass of water. Because everybody here is dealing with this complex disease. So the person who said, I haven't the capacity, we don't have the capacity. It's not easy all of the time. And I am going to finish with this because I think somebody actually summed up quite nicely. And she said, on the medical side, it would be good to have a clinic, to have somebody organizing the chaos, somebody organizing that things are done in the right way, somebody organizing that the bloods are done before the appointments. And then if 3 doctors want blood, to pool them, then I don't have to do that myself. It should be good to have one place to go and maybe get your needs out of the way in a day. So you don't have to go 5 times a year. That would be really helpful. And on the other side, we just need resources because it is true. We've got the specialists for the epilepsy, the nephrology, but we have attached to all of the TAND, we've got speech therapy, physiotherapy, occupational therapy, and education, and the school nurse who knows nothing, and the teachers who know nothing about TSC. I mean, you've all been down there to tell the teachers. I don't think there's anybody in the audience who hasn't had to go into school and explain all about TSC and reassure all the staff. And then they change teachers, and then the child changes the year, and you have to go back again. So in fact, we have educated some of the country, but that's not fair that you have to do it all the time. So we need the resources. So that's what I heard. Now, this is a French neurologist who published How to Set Up a Clinic. And that's where we're at. And Claire and Professor Doherty are doing this. Now, how can you help? And I mentioned this earlier. Part of this study, this research study, is to gather what is happening in the country. I've interviewed some of you. Those of you I've interviewed completed these questionnaires after the interview. Those of you I have not met and have not interviewed, please, please, it's anonymous. I will not know who filled it out. I don't want to know who filled them out. And there are 3 simple questionnaires, one about TSC and one if you have epilepsy. And that study was done across 7 European countries. And we will have some idea as to how we measure up. We'll be able to prove to the government, hey, you've got so many people have difficulty this way or that way. That will give us power when we're looking for resources. And then any of you who, it would be great if you could speak to your clinicians and tell them that I just want to interview them for 15 minutes. Again, it will be anonymous. They won't be known. You won't be known. And I just want to know what it is that they need. Okay, so I know what Professor Doherty needs. He's here, but I won't know what so-and-so needs down in Kerry. I won't know what your GP feels that he needs. So please just reach out to your clinicians and say, I want to know what they want, because unless we know what they want, well, they're not going to get it. We can't ask for it if we don't know. And it's only 15 minutes, 30 minutes. Then the TS support group. The TS support group, Tony is better at giving the full history of this, but this is a group set up by parents, founded by parents who are still here, Chris, Tony, others, who set up the support group. And the aim really is to raise the awareness of TSC and then support the people as well and get this whole TSC thing sorted. So please join TSC. And I should probably say there are activities lined up when it comes to education. There was already a TSC education webinar done for the 15th of May. Unfortunately, it didn't get recorded as was planned. We plan to have more so that ye can learn, that ye can be empowered to cope with the disease and to be supported as well. The other thing that's happening in the country, and Professor Doherty mentioned it earlier, there are rare disease pathways. So from the high level, first of all, it will be the first time that the government will have anything in their hands saying, hey, there's a crowd out here of people with rare diseases and this is what they need. And that is in development. It's a bit complex looking, but know that it's happening. And it is also tying in with what you know is happening, that they want people outside the hospital to be looked after closer home, in their home. So it will be tying in with that, which means that maybe you'll be able to have your blood test done. You won't have to run to the other side of the country. You'll be perhaps able to link in virtually with some of these people. So all of that is happening in the background. So just know things are happening, but they should be happening faster. Outside that again, so I've gone from the support group outside into this network that's happening in Ireland. And this is another network which is now beginning as well. And it's a rare disease clinical trial network. And when I say clinical trial, it doesn't mean that they're going to be giving you new medication or injections or something. Clinical and trial involves like questionnaires, finding out Dr. I can't say her name properly. Agnies, her type of study, which is so important, which is going much deeper into what I'm doing in the burden of illness and quality of life. They're really important. So they're the type of studies that can happen in Ireland. And it's a huge network. It's international. It's European. And really, it's important to get involved as well in research, because you can see that's how things progress. It's when the people doing the research look and then give the results. And outside that again, for the very first time in 2021, in December, the United Nations adopted the very first ever UN resolution on addressing the challenges of people living with rare disease and their families. So it means that this whole support and recognition that people are struggling with all of these diseases and that things need to be done, it's happening from the very highest of levels and filtering down. But all of this takes time. So we need to get it from the top and from the bottom. And that's what's happening. And the other thing is that the WHO, you've all heard of it, like every year they pick something to make care safer for patients. So you will have heard of safe surgery or wash your hands. And last year it was medication safety. And that is something, just as a little side note, that is starting in some hospitals, that when you get your appointment, you know this letter, the one that you don't want to get, half a dozen of them, but that on the back of it will be a space for you to write in the medications you're currently taking, so that when you go back with this appointment letter, that your clinician can just turn it over and see, oh, this is the medication. He doesn't have to go back through half a dozen pages and files. Taking in your medication list is good for you and good for your clinician. So some hospitals are doing it. We're trying to get other hospitals across the country. And even if the hospitals aren't doing it, take your medication list in with you. Even if you think that that's the doctor who prescribed it, take it with you. So this year, the theme is to engage patients for patient safety. And in the group I'm not the only one on the WHO. I am actually one of the advisors in the smaller group, but there is a wider group of patients for patient safety here in Ireland. There are just about 6 or 7 of us on it. And we're developing and working with the HSE on health literacy, is helping people to understand the language around. So I'll try and get you involved in that as well. But really, it's a unique opportunity for patients to be involved in moving their care forward. It's engaging patients for patient safety. And the slogan is, I've forgotten, I had told it 2 minutes ago. And then there's one other thing that you can do if you want to learn a little bit more about TSC and get your clinicians, every single GP that you are dealing with or their students. And every time I happen to have been in the hospital, anything around TSC or anything else, I get the young intern and I say, have you done this module? Go home and do it and come back in the morning and tell me more. Because there's an excellent module. It only takes an hour and it won't frighten you and it will give you the education you need. And certainly the medical students, and there are 3 of them up here who have learned all about TSC in the last couple of days, They haven't done the module. They still have to do the module, but they should. And this then, I suppose it came across in practically every interview I did, was how people felt when they were told about TSC. It's the negative side was always, she's never going to do this, she's never going to do that. You know, all these horrible things that you've all been told. And it has come as a shock out of the blue. It's a word you have never heard of before. And sometimes it was delivered by a person who's probably themselves scared and telling you about this, not knowing how, and who would have come across as being, you know, not being human, as somebody said. But then I have heard how other clinicians, including Professor Doherty here, they were able to compare how they were listened to, how they were supported in the breaking of bad news. So this actually was a slide I had not for you today. It was one for the clinicians yesterday, that when they are actually breaking this bad news to families, just put a positive side on it. You know, I know when I was told about my daughter's illness, I was given a big long list of what she was not going to be able to do. And I took the list up. It was Professor Dulac, you probably know of him. And I balled it up and I left it in his wastepaper basket. And I said, I don't want to see the list. I'm going to see what she can do. Because I didn't want a whole load of she can't do. So keep, you know, the positive side up. When you're told something isn't, these poor doctors are so much into all of the, and there's been a huge change, and I think Professor Kingswood would know that as well, and Professor Doherty, you know, the thinking of all those years ago of what wasn't going to be, and all of the intellectual disability that was going to be attached. Yes, there is, and yes, there are problems, and we heard all about TAND, but keep it positive and try and grow the positives. So I think that's the end of my slides. And I didn't say thank you to the people who put up with me for the interviews. So thank you so much. And all of that will be put together in different reports and published so that people can hear about TSC and maybe try and understand just a little bit what it's like.
Thank you very much indeed, Mary. That was great. I should say, I mean, really, Chris needs no introduction in the field of tuberous sclerosis. He's a renal physician at Brighton. He works in the St. George's Clinic and is one of the forefronts in tuberous sclerosis and the renal disease in tuberous sclerosis as well. Thank you, Chris.
Thank you, Charlie. I'll just point these down at me. Just want to say a thank you to the TSC Ireland for inviting me, and to Professor Doherty as well, and to Carla and Mika for organising. I'm still here from their hiding, and organising meetings like this around Europe, which I think is very important when you're struggling with the unknown, to get as much information as possible. And things have changed dramatically in the last 20, 25 years in TSC. There's a lot more we can do now, and some things we can't, but we'll go over those. You've seen this before. Mary showed you, has done some of my work for me. She's already shown you a few of my similar slides, but different things become more important at different times of TSC. The kidneys usually start to become important after the age of 5, but occasionally there's a problem before. So with the kidneys, it's best to keep an eye on them throughout, from the first time of the first diagnosis right the way through life. And things before 2008 looked a lot worse. This was what we knew, that the most risky things that families faced were a SAGA, which occurred in 10 to 15%. About half people with TS might get a kidney bleed. LAM occurred in a significant minority of ladies with TS when they became adults. The facial rash was troublesome. Epilepsy, which occurs about 90 to 95% of people born with TSC have epilepsy at some point, but still 40% have refractory epilepsy difficult drug-resistant epilepsy in adulthood. And then TAND, which I will say a little bit about later. Just to go back to the mTOR pathway, so to highlight a big advance in TSC. So the job of the TSC1 and TSC2 genes is to turn off the growth and division pathway in cells. But you've knocked out both TSC1 or both TSC2 genes in a cell, then that pathway is uncontrolled, and that cell will continue to grow and continue to divide. And in peripheral, in things like kidneys, skin, you'll get continued growth. And the biggest advance in one of the biggest advances in TSC was the discovery of everolimus and sirolimus, which act like the TSC1, TSC2, and they block that pathway, so they control the cells. So that was a big advance. And that led on to a number of trials to look at the effectiveness of those treatments in various aspects. And the mTOR inhibitors, sirolimus or everolimus, are very good at controlling SAGAs. They're very good at halting the progression of the kidney disease. They also halt the progression of the lung problems. They're very useful for the rash. The earlier you start it with the rash, the more effective it is. And that will be even more important when the new sirolimus cream becomes widely available. In the UK, it's going to be licensed for treatment in September. And we hope that it's potentially spread out throughout the world very quickly. mTOR inhibitors also do help the epilepsy somewhat, but the problem with epilepsy is only a third of the mTOR of the everolimus in the blood gets into the brain, and so you can't really get the levels high enough in most people to get a good effect on the epilepsy without causing a lot of side effects from getting the levels far too high in the blood. So they're worth a try, and they do work to a greater or lesser extent in the minority of people, but they're not good for everyone. And you've heard about cannabidiol this morning, which is another thing which can be used as well as an mTOR inhibitor, but it's certainly also worth trying. TAND was the last most difficult problem to sort, and is still difficult because there are not many effective treatments for TAND unless you stop it happening in the first place. And that is tricky. But at least with the TANDem app, as Professor Agnies was explaining, we have a roadmap. We can now document, once it's in the hands of families, exactly what's happening to their individual member with TS, and also what treatments are available and what yet needs to be researched or worked on. It doesn't mean to say that will always lead to the treatments that are available, because in a lot of places there's a lack of resource. But if you've got documentation from which to advocate, you can start agitating to have the resource put in everywhere. And then guidelines, and these are available on the TSA website to download, but there are guidelines which you can show to clinics and doctors about the various aspects of TS that need to be monitored and what treatments are available. And sometimes this is a sort of universal problem throughout the world. It's okay to know a bit about what's going on, but if it's a rare disease, the person who becomes the expert is the parent, really, or the person with the disease, and then they have to advocate and fight for the resources. As Professor Doherty was saying, the expert doctors can lobby, but they need also the power of families to lobby effectively. So onto the kidneys. So the main issue, 80% people get AMLs in the kidneys, and these are the main problem. Many people get cysts, which cysts are when the TS cells that are formed in the kidney secrete messages that tell other normal kidney, or what would be normal kidney cells, to turn into cysts. They're less of a problem High blood pressure is a risk, and it's common in the general population. It's commoner in TS, and it's easily treated, but leads to significant damage if not controlled. We'll talk a bit about premature loss of kidney function. And then rarely you can get other kidney tumours, such as kidney cancer and other benign kidney tumours. But to start with angiomyolipomas, this is from the Tosca data, and it showed that angiomyolipomas can start very young, even less than 2 years of age, but get increasingly common as people get towards and beyond 40. So about 80% of people have significant size angiomyolipomas by the time they're late adults. And in half of those, they've needed intervention, either because they've had a problem or because it's preemptively they've been spotted as growing to a size that will cause a risk. And what we've worked out from the studies from the past is that if a single AML is 3 centimeters and still growing, then there is a risk that it will cause a bleed, and that risk goes up exponentially as it gets bigger. And the risk is sometime over the next 5 to 10 years. So that's our treatment threshold. The mTOR inhibitors are very effective, and they're equally effective. Sirolimus and everolimus, there's nothing really to choose between them, apart from which one's available in your clinic. And they will control AMLs, they will stop them bleeding, and they will shrink them to some extent. And that's the amount they shrink is variable, but it's not important. All we need to do is stop them growing. So we stop the blood vessels expanding. But the mTOR inhibitors are a partial inhibitor. So all those organs that the TS affects also the normal cells rely on the mTOR pathway. And so we don't want to inhibit the normal cells, but because mTOR inhibitors only partially inhibit the mTOR pathway, and the TS cells are exquisitely sensitive to that effect, the normal cells are much less sensitive. So you can get away with giving a small dose of mTOR inhibitor for things in the kidneys or the skin or the lungs, and lower the dose to control those TS cells without causing too much in the way of side effects. So for AMLs, the situation's radically changed, and we should, providing someone's been screened for them, providing we're monitoring them, providing we know about them, we can do something about them. This is some data from before the era of mTOR inhibitors from the 8% of the population in the UK, which we surveyed. And it shows that about 40% of people with TS get premature kidney impairment. That is a sort of GFR dropping below normal to varying degrees. In most of them, it wasn't low enough for them to need dialysis, but it's low enough to increase the risk of blood vessel diseases, cardiovascular disease. So not getting to that place in the first instance, it would be an aim. And a lot of that was due to the effects of the AMLs and growth of AMLs and then damage to the kidney when dealing with AMLs by embolization or surgery. But some of it's due to other things in TS. Not having enough normal kidney cells is one thing. Untreated high blood pressure is another, which is another eminently treatable thing where you can prevent kidney failure by monitoring for and treating blood pressure early. And possibly the small AMLs as well, if there's too many of them. And so if you inhibit them with an mTOR inhibitor, you may help preserve kidney function. And indeed, in the Exist 1 and 2 trials, where we looked at the effect of everolimus on AMLs and on SAGA, the kidney function in those people over time, over 4 years, was pretty stable on the whole, apart from the few who started with very poor kidney function in the first place. So that was reassuring. Other kidney problems are much rarer. Certainly kidney cancer can occur. 2 to 3% is the same as the current rate of kidney cancer in the general population, but in the general population, it occurs at a much 2 or 3 decades later than in TSC. So it's something that needs to be monitored for. And it can be treated by removing that tumour if it gets too big. If it's very small, or if we're not sure what it is, we might just watch it from year to year. The same is true of there are rare benign tumours that often will grow for a while and then stop growing. So if you know what they are, they can be just monitored. Simple cysts occasionally contribute to high blood pressure. But as Professor Green explained this morning, in 5% of patients with TSC who have knocked out the TSC2 gene on chromosome 16, they've deleted the whole of the end of that chromosome. So they've lost the APKD1 gene, the polycystic kidney gene, as well. So they get 2 diseases. They get TS and they get polycystic kidneys. And they are more prone to getting kidney impairment early and high blood pressure. So that needs to be monitored for and needs to be, blood pressure needs to be treated. They may need supportive care. It's possible that sirodemus or everolimus will help prevent progression, or something new called tolvaptan, but that's still being trialed at the moment. And then pulmonary lung disease. So lung disease is really, most of it is from the kidneys, which is why I'm mentioning it in this talk. Some degree of LAM will occur in most women by the age of 40, but only a minority, possibly 5 to 10%, will get bad enough LAM to affect their lung function. And sirodemus and everolimus are very effective at just completely halting that process, but obviously it's best to do that before they start to lose any lung function. And it's just to explain that it's the AMLs in the kidney, little cells break off from them, TS cells, and circulate in the blood, and they seed in the lung. And that's where most of the LAM comes from. Sometimes those TS cells start elsewhere in the body and get to the lung, and sometimes they might start in the lung. But as I say, they can be controlled. And this is a group of ladies who we treated in the UK with sirodemus, and they had LAM and their lung function was declining. But it was already a lowish state to begin with. So by the time they started sirodemus, although we slowed down any change in their lung function, we didn't halt it entirely. There's a big study going on in America now to look at starting much earlier, which I think that will show very positive results. So monitoring. So what's the minimum monitoring you need? Well, blood pressure, very easy to do for most people, and an annual blood test to look at kidney function is useful. Sticking the urine is important, but because we like to look for protein in the urine, but there's a caveat that most people with AMLs will have some microscopic amount of blood in the urine. And it's that even the ones who are on an mTOR inhibitor and who are never going to bleed. So seeing if someone has actual blood that you can see, visible blood or visible hematuria, as we call it, that's a very important sign. But if they've just got microscopic amounts, that's nothing to panic about, because most of our patients have that on every visit to our clinic. And I'll mention that because when you take someone with TS to see a nephrologist, they will, if not very experienced, they will immediately start to worry. But microscopic blood in the urine is a sign that they've got AMLs or something else in the kidney. Annual kidney imaging. So in our clinic, St. George's, we prefer to do MRI scans as the first choice. And we do that because sometimes you miss big, fat, poor AMLs with ultrasound. And CT scans give you a dose of radiation. And we've had an argument for some years with our radiologists about the resources and extending the MRI time scan, because they say, well, can't you do an ultrasound and an MRI of the brain? But if we're doing an MRI of the brain every year to monitor for SEGA, it seems sensible to just extend the time and MRI the kidney as well. So but it does depend on your local resources. It's better to do something rather than nothing, and an ultrasound will pick up most of the problems most of the time. CT scan can be used, and there's a couple of our patients who have nerve stimulators buried in the chest, and if you've got a sort of metal box and a pacemaker in the chest, and a vagal nerve stimulator, you won't be able to CT scan that person, MRI scan that person's abdomen, because the high magnetic field in the MRI scanner will interfere with the box, and the box may move. So then you have to do a CT scan or an ultrasound. Once someone's on an mTOR inhibitor, we're now so confident that it works almost all the time that we stretch out the annual scans to once every 2 years or 3 years, and are less worried. So that causes less of a burden on the person. And the other monitoring is a lung CT. So you need to look in a woman, you need to look for LAM. And the first thing to do is to start at age 18, because it does come on late. And then if it's clear, once every 5 years, but if you see some changes, you may need to do it more often. In those who can participate, doing some breathing tests is helpful as well, because you want to pick up the moment that starts to change. But you can get quite a good guess about what the breathing test will show from the picture of the CT. So you don't have to have the breathing test to start treatment. And it has to be a CT, because MRI scans can't see the lung very well because of all the air. It interferes with how the MRI works. So when to start treatment? So the UK indication, and it's slightly different in different parts of the world, but what we can get reimbursement for when we prescribe everolimus is if the AML is 30 millimeters and growing, or if we expect it to grow, which we would do in anyone under the age of 35 or 40. However, if someone's got a 25 millimeter AML and they're 8 years old or 10 years old, that's definitely going to cause a problem. So we would consider starting treatment early, particularly there's another reason for that person to have treatment. Blood pressure, very easy to check, very important to control, and easy to do so with lots of medications that work. In an adult, blood pressure should be an average of 140/80 or less in everyone. And then children, as the smaller, the younger the child, the lower that threshold is. For other tumours, if you've got a very small renal cell carcinoma, you can probably watch it, providing you waiting to see what it is. But what we normally do in our clinic, and they are rare, is if we have a fat, poor lesion, we're not sure. Most lesions, if you look at them carefully enough, and they're AMLs, you'll see the fat with different CT or MRI techniques. But in the very few where you're just not sure what the solid lesion is, we would do a biopsy to see. If it's a carcinoma, we would consider removing it surgically. Occasionally, in an older person, you can fry it by putting a probe in. Other tumours, like the benign things, oncocytoma is a commonest, you can just leave and watch for a while, and they will often grow and then stop growing. But you do need to watch them. You also get other things in the liver, but they almost always stop growing as well. I mean, mainly it's AMLs in the liver. The AMLs in the liver don't become fatty, so you have to be able to recognise them, or your radiologist needs to be able to recognise them. But I've only ever treated 2 patients for an expanding, growing AML in the liver, out of a few hundred. And then in the lung, if you've got LAM nodules and cysts is the main sign of primary LAM, and any impairment of lung function, then you should start treatment. So red flag, we had a discussion yesterday with the doctors about the red flags, the things that should have you making an emergency call, either or taking someone to the A&E. And these are, if someone has their first new seizures, that's a red flag, and those people need to go to A&E and be checked out, because that could be the first of many. If you have status epilepticus, which slightly different definitions in different countries, but if a seizure is continuous and not responding to treatment after 10 minutes, then that's the time to call the ambulance. If someone has seizures but they're very stable and they suddenly get a lot worse, that might be a SAGA growing and causing high pressure in the brain. So that needs urgent investigation. Severe headaches, the same. If someone develops very severe intractable headaches, and particularly if they're waking up with them, that could be high pressure in the brain due to a SAGA. And then more subtly, if someone suddenly goes off in their behavior or their ability to think and to cognate, even when they've been reasonable or stable before, then a red flag. Going blue is a more difficult one. Quite a lot of people go blue in the middle of a seizure for a few minutes. But if they've never done that before, then, and you're not used to it and you're not used to getting them through that seizure, or if it's not related to a seizure, then again, there may be a cardiac problem or abnormal heart rhythm, and you need to go to A&E. And if you see blood in the urine, if it's bright red blood, don't bother trying to call the GP, just A&E. And by a similar thing, the other sign that you may, not all kidney bleeds come out in the urine. Sometimes they may bleed internally into the kidney. So if you have someone who develops severe tummy pain, that's, again, time to call the ambulance. So that's all I want to say, but I'm very happy to answer questions and expand it.
Just going to finish off really with my thoughts about living with tuberous sclerosis, although some of it has been covered by Chris, and just to chat about it. So just let's have it, it's towards the end of the day, let's have it as a sort of nice wee chat. So if anybody wants to ask any questions or make any points through the talk, please just raise your hand. I'm quite happy to stop and going. It's just some of my thoughts about living with tuberous sclerosis, and certainly since 1987, when I started working in tuberous sclerosis, there has been a lot of changes, a lot of advances in the treatment and care of what's essentially not a very nice disease, and try to improve the quality of life of people with tuberous sclerosis and to try to help them. The one thing when you write papers in tuberous sclerosis is you always seem to start with this sentence, and I often think, of a person parents whose child has been newly diagnosed with tuberous sclerosis, and they picked up some of the medical papers and they saw this sentence and think, what the hell is going on here? So I just thought maybe the first thing to do is try to explain this sentence. Tuberous sclerosis complex is a multi-system genetic disease. It is inherited as autosomal dominant. The main organs affected are the brain, the kidneys, and the skin. Lesions have been described in other organs such as the heart and the lungs. So let's just go through that. Well, genetic, as we heard from Professor Green this morning, means it can be inherited as passed on to the next generation. It is autosomal dominant. Autosomal, well, autosomes are the chromosomes which are not the sex chromosomes. The sex chromosomes we have are the X and Y. And I don't propose to make any stupid remarks about intersex or any of the controversies at the minute. But the autosomes are the other chromosomes, and chromosomes come in pairs, and you get one from each parent. And in tuberous sclerosis, one of the genes, which is really just the mass of genetic material on the chromosome, is defective, and it is either in chromosome 9 or 16. And this has been very well explained by Professor Green. Autosomal dominant means that only one gene of the pair needs to be defective for the disease to be passed on. And all people who have the gene are affected with tuberous sclerosis. So in other words, it is passed on, it is fully, there's no sort of silent type of it, although there are many different forms of tuberous sclerosis. Children of a person with tuberous sclerosis have a 1 in 2 chance of being affected. And people with TSC can be affected by different degrees of severity, from having minimal symptoms to being severely affected with epilepsy and severe learning difficulties. So that's really is what that sentence means. So what do you have to live with tuberous sclerosis and tuberous sclerosis complex? Well, what parents and patients have to live with is the burden of genetic disease. And what I do is it'll go through the sort of 3 or 4 things that I think are the main problems that parents have to live with, and how, with the modern advances, it is easier to cope with them. I'm not saying it's easy to cope with them, but it's easier to cope with them than it was a long time ago. So there is the burden of genetic disease. And what do you have here? Well, I think the one thing is, in tuberous sclerosis, the signs and symptoms are quickly recognised. And that is important. My first study of tuberous sclerosis in the west of Scotland, in Glasgow, where I looked at seizures in patients with tuberous sclerosis, there was lots of cases where there was a real delay in getting it diagnosed. And a lot of people mistook the infantile spasms for colic. And as we've seen from the talk on epilepsy, uncontrolled seizures mean uncontrolled damage to the brain, more chance of learning difficulties, so the signs and symptoms are quickly recognized. And I'm glad to say now that the signs and symptoms are being quickly recognized. The infantile spasms are being recognized. Children are getting the CT scans and they're getting diagnosed a lot quicker. Certainly that is the experience in Northern Ireland. All people with tuberous sclerosis, that they have an expert genetic opinion. So they go and they should expect to see an expert geneticist who is well versed in tuberous sclerosis. And as we've seen and heard about all the sort of unrecognized bit, these somatic mutations and everything, it is important that they have a good expert, a genetic opinion. As we know, the defective gene is located in chromosome 9 or chromosome 16. And all patients should be, the blood should be taken from them to find out exactly on which type of tuberous sclerosis that they have, and which it's seen. As we've seen, tuberous sclerosis 1, the symptoms are slightly milder. Also, it is important in the genetic counselling that the parents are screened and that they have expert genetic counselling about the risks of having another child. And certainly, I have seen families in Northern Ireland, where the mother has had tuberous sclerosis, but she didn't know she had it and kept producing, she had 3 children with tuberous sclerosis who had the full-blown tuberous sclerosis. And I think from what I'm hearing this weekend, probably the mother had a somatic mutation. And that the parents are, if they want to have other children, they're offered the various choices. And I think I've said here selective fertilization, but I think that was one of the choices that Professor Green put up in his slide today, that parents should be offered. But you should have a full choice of what to do, to try and avoid having another child with tuberous sclerosis. Tuberous sclerosis is a multi-system disease, so it can affect different systems. And I'm going to deal really here with the skin, the brain and the kidneys, which are the conditions that are primarily affected by the disease. Other ones, the heart, lungs, are not as commonly affected, but it can affect different systems. And as you know, we all know there's different phenotypes of tuberous sclerosis. Not all patients have intellectual disability. 90% of patients have epilepsy, but there's some patients are seizure-free. 45% of patients have kidney disease, and not all patients have the full manifestation of the skin disease. So there's many different forms of the condition. In the brain, tumors in the brain, and tumors are really just abnormal tuberous sclerosis material, which is in the brain, and this can cause epilepsy and learning difficulties. And then, as you know, our brains, we've all got holes in our brain, probably some bigger than others, but these holes are called the ventricles, and our brains actually suspend in the skull in fluid, cerebrospinal fluid, and the fluid circulates round. And then these calcified nodules in the lateral ventricles can grow, and they can cause a brain tumor called a SAGA, which is unique to tuberous sclerosis, and it is a slow growing tumor, and but it is a significant risk in patients with tuberous sclerosis. It usually occurs in the first or second decade. It's slow growing and usually presents with headaches, and patients can have ataxic symptoms, but usually with headaches. So what parents really have to live with due to brain problems? They have to live with the epilepsy. They have to live with different grades of learning difficulties, which can occur at any age. As we've heard from Agnieszka, they have to live with behavioral problems. And you have to live with the fear of the brain tumor. Your child has a chance of having a brain tumor. So let's deal first with living with epilepsy. And epilepsy is, as I say, 90% of the condition. Now, one of the things in the general terms for they're talking about living with epilepsy is that you have an accurate diagnosis of epilepsy, that you make sure the patient has epilepsy before you start them in treatment. You try to get as accurate a diagnosis as possible. With tuberous sclerosis, you have a pretty good chance of being right to say that the person has epilepsy. So you have a good, accurate diagnosis. You get a prompt diagnosis. You get good investigations, EEG, MRI scan if possible, or CT scan. That if medication is required, that the medication has minimal side effects and the medication is explained. And certainly one of my things when I ran an epilepsy clinic was that you just don't you say a child with epilepsy and say, oh, your child's got epilepsy, take these tablets once a day or twice a day, and out you go, and we'll see you in 3 months. You need to actually take the medication and you work it out exactly the dose in milligrams per kilogram. You look at the dose and you look at the preparations available for the child to take. A lot of children don't like taking tablets, and a lot of the drugs have alternative preparations available. Epilim has the granules. Topamax has granules as well. And in cases you can make syrup. Lamictal has the various preparations, soluble preparations to take it. So that's important for children. It's not so much adults. I mean, most adults can take tablets, but some children, they just can't swallow the tablets properly, so that you actually work out the medication, explain how it's taken, explain the side effects, explain why they're taking the medication. And certainly it's only reasonable, I think, to give a child a medication twice a day. The medication is monitored. In other words, that there's good regular reviews, and that you have a fail-safe for the parent, that they can phone you up and say, my child has had a seizure, or my child has got side effects from the medication, and you can either advise them over the phone or you can see them at your next clinic. So do you want to monitor the medication very promptly? You want to try and ensure good compliance with the medication. You want to, as I said here earlier, you want to look and see which preparation is available. And then really, one of the things in epilepsy is that you do have to give advice, and this is where your epilepsy nurse is most useful. You want to give advice about how you monitor the lifestyle and identify the triggers, and advice about the activities, and certainly where I lived in Craigavon, there was a few kids that you had to say, well, you're not allowed to drive, because a few of them had their cars and they would drive them around the fields, and or their mini tractors and drive them around the fields. So you had to sort of stop the driving, and there were 1 or 2 of them were very cross with me when I stopped them driving. But you have to think what they're doing. Are they in danger? about their activities. But again, you want to try and make sure that they have as normal a lifestyle as possible. And these are all the things that really epilepsy needs. And the main thing that one of these things, and I did leave this one out actually, I'm sorry to say, when I was doing the video, is that you need a good emergency plan for seizures, you know, so you need to have some rescue medication, have some at the school if the child is school age, that you can take into school, that if the child does have seizures, that they're able to be given it. And some of the schools, the staff will need training on how to administer it, you know, and as you know, the sort of staple of emergency management for seizures is buccal midazolam to give, but you can give the rectal suppositories, and I think they're perfectly good, although a lot of people now are loath to give the rectal suppositories. Learning difficulties, not talk too much about this because Agnies has talked quite a lot about these, but certainly in that to have good quality of life, the needs are identified and provided. And very easy for us to say that, you know, but very often, you know, the schools just don't have the resources, they don't have the staff that are needed to help people with special needs. And it can be a constant battle to actually get what's done, even though the Education Act, certainly in the UK, makes provision that the needs of a child needs to be provided, but it's not always done. And I'm sure a lot of you have had battles with schools and nurseries to try and get the resources needed to help the child. Again, behavioural problems are very common in tuberous sclerosis, and we've heard that from Agnieszka as well, about the difficulties in doing that and the access to proper services and proper management for behavioural problems. And just sort of finally, the one thing I should say again, just to emphasise about the risk of the SEGA and the brain tumour, and as Chris says in his talk, you know, one of the red flags is the child with headaches. You know, you get an ordinary child with headaches, you say, oh, well, you know, when are the headaches occurring? And they just hold at the end of the day, and you just realise they're tension headaches and you don't need to do a CT scan. But a child with tuberous sclerosis, they're complaining of headaches to you anytime during the day. You need to think about, you know, does this child need a CT scan? Certainly somebody should have a look in the back of their eyes and the optic fundi. Does anybody have any questions? Can I just stop there and just see if anybody wants to raise any points? Sorry. Well, difficulty, you know, if he's not sleeping at night, if he's waking early, vomiting, you know, or you just feel he's distressed and you feel that he's just not, you know, just you feel he's not himself. You know, it is difficult, but it's something. And generally, I would say, you know, a child that if the mother comes to me and says, well, I'm just not happy that he's just the same child, doctor, I just think there's something going on, I would say, let's get an MRI scan on him just to make absolutely certain. Or if there's problem getting an anaesthetic for him and difficulty getting an anaesthetic, I would say a CT scan. Certainly a very low threshold of doing it, because SEGA is something you want to get early rather than late. Right, okay. So we'll just move on, I think, really to the problems of living with kidney disease. And kidney disease is 45%. As you see, in childhood, you know, kidney disease starts mainly really about 10, although it can occur earlier. And they're really angiomyolipomas. Sorry, I should have put, I've misspelled that. Benign, which are really benign tumours of fat and muscles. And the big danger of angiomyolipomas can cause bleeding, or they can compress the kidney, causing renal failure. Now, one of the most effective studies I did was a very simple study, and Sergey kept reminding me of it, was looked at in the Mayo Clinic population of children with tuberous sclerosis. The mortality really from untreated angiomyolipomas, and the big cause, one of the major causes of death was uncontrolled bleeding from the angiomyolipomas, or as Chris says, concealed bleeding, a little bit of hematuria, but a lot of the bleeding was actually into the tumor, causing the child to collapse and couldn't cause death as well. So the angiomyolipomas can actually cause death by bleeding, or they can compress the kidney, causing renal failure. And as we've heard, there's a small proportion of children, especially with the TSC2 gene, where the defective material is really over chromosome 16, and it affects the part of the adult polycystic kidney disease, and the child can get renal cysts. And certainly on the mortality study that I did a long time ago, there was 1 or 2 deaths from children who had renal cysts. So that's another thing that you can get from the kidney disease. So what are the requirements? Well, as I've said, Chris says renal scans, a diagnosis of tuberous sclerosis to identify kidney disease. If no kidney disease is not established, well then less regular scans just to see if the AML have developed. But if there are AML, regular renal scans to see if the AML is growing. And I think that really is a sort of almost a negotiated type, one of the scans between your radiology department and yourselves, because certainly to get an MRI scan every year, I don't think is possible in every hospital, and sometimes you have to make do with an ultrasound scan or even a CT scan. But regular renal scans to see if the AML is growing. And one of the things that we're going to do, and Chris is going to do, is that we're going to approach the Royal College of Radiologists to see if we can get better protocols to see if we can identify AMLs are growing, because sometimes the reports are very vague to tell you if the scans are growing. In the skin, as you know, you've got angiofibroma, the depigmented macules, you've got the flat forehead plaque, and you've got these horrible growths on the nails, the periungual fibroma. And really, the big one is patients find really is the problems with the angiofibromata. And we tried laser therapy, and laser therapy has a reasonable treatment. Now, everolimus cream is beginning to get more on the go, and certainly in Northern Ireland, I believe we can get some of it for some patients. But it is becoming more popular and certainly more acceptable now. But we struggled for a long time to try and get approval for everolimus cream. So requirements again, a dermatology referral, you should always see them. The children should always be referred to dermatology, as I say, laser treatment or everolimus cream. One of the things, how do we achieve all these facilities? And we've talked about them and tried to bring them on. And certainly, I'm a great believer in parent power. The Tuberous Sclerosis Association in the UK was set up in the mid-1980s by a group of very powerful, assertive parents who really had children with tuberous sclerosis, and they got fed up really going to doctors, and doctors saying, well, I'm not terribly certain about this and I don't know about that. So Janet and David Metcalf, Anne and Tom Carter, Graham Harker and Anne Hunt were, sort of parents that didn't take no for an answer, and they set up the Tuberous Sclerosis Association. And what they did was that they went to the top and they invited Manny Gomez to come over from the Mayo Clinic to talk to them, to actually educate the doctors about tuberous sclerosis. And certainly I feel it shows the power of the parents, and parents need to be very assertive. And I certainly agree with what Colin was saying about a special tuberous sclerosis clinic. What are the positive points that we're seeing to allow a better quality of care in tuberous sclerosis now compared to when I started in 1987? And everolimus, the introduction of everolimus, specifically the mTOR pathway inhibitor, and I'm sure you're fed up hearing about it, but it has been a great success in tuberous sclerosis, especially with the angiomyolipomas and the SEGAs. There are undoubtedly better epilepsy drugs of it, better diagnosis of the condition. Very important is good information on the web, and I think that's very important. One of the things we've talked a lot about GPs and GPs knowledge, but one of my jobs is actually tutor for the Royal College of Physicians here in Dublin on the Diploma of Paediatrics course. And we teach GPs in Ireland as well as all over the world about it. And it is, as Colin says, unrealistic to expect the GPs to know, or the emergency doctors who we teach, to know about every rare condition and everything to know. But what we do 2 sessions on genetics and chromosomal problems. What we do teach them is, it is okay to say to parents, I'm not sure about the condition, but I will find out. And I think that's very, very important, the information on the web. I always remember when I was a houseman in the city hospital. I don't know, maybe I show my age. If any of you remember a show called The Pink Medicine Show, and I did check it up. It is on YouTube. You can still watch it. But there was a doctor there called Rob Buckman, who was a very good comedian, but he also was a very good doctor, a medical oncologist. And he came across to lecture us on and talk about communication skills. And I always remember one of his very important points was, he said, doctors are very bad at saying to people, I don't know about something, and he said, don't be afraid to say, I don't know about something, but qualify it with, I will find out. Or I will refer you to somebody who does know, but I will find out. And certainly in nowadays where care is fractured, and emergency care, you don't go to your normal GP, you maybe have to go to the emergency room. It is important, that if doctors don't know about rare conditions that come in, that they're able to find out. And the web is absolutely fantastic. It's full of websites that you can get information about all these conditions. And I certainly have the uptodate.com I use very frequently, certainly in teaching, to get good information on the web. The one example I do give when I'm teaching to the doctors is the child with tuberous sclerosis comes in, you're the emergency room doctor, you're doing there, the child comes in with hematuria. Well, for a normal child, what you do is you check the urine and you think, have they got a urinary tract infection? With a child with tuberous sclerosis, you check the urine, look for the blood, and you think to yourself, have they got angiomyolipomas? Is there a problem in the kidney? Get them a scan of the kidneys and maybe get a urology consultation. So one of the positive points, I think, nowadays is the ease that we can get good information about rare conditions on the web. We do have much better scanners now. I'm not an expert in that. I leave that to people like Tony Gagan about talking about the different types of scanners, which are good ones or which are bad. But certainly they're much more specific now about identifying abnormalities. And I think the big thing is the identification of the gene, which was done by Professor Sampson and Andrew Green and Professor John Yates in Cambridge and Cardiff. And that allowed us to make a definite diagnosis of the condition. But as I said, and as we've heard from this morning, if you can't find the gene, it doesn't mean that the person doesn't have tuberous sclerosis, because it's essentially a clinical diagnosis as well. But those are the positive points, I think, in trying to improve and helping us to live with tuberous sclerosis. So I'm just going to finish there and say thank you to you all for coming, and thank you to you all for listening.